Before giving the floor to Sophocles to introduce our new panelists or reintroduce them, I would like to say that this part number 2 of today's meeting is slightly different to part number 1. So how it is constructed, we have 4 topics and 4 or 5 experienced presenters. And for each topic, there is 1 or 2 or 3 cases prepared, which we'll discuss on. And in this way, in this format, we'll be able to focus and touch on the most controversial part of each topic. Sophocles, would you like to introduce our panelists who are different to part 1? And
Yes,
then
Michalis.
I go on.
Well, apart from thanking all the presenters and panelists of part 1 who have been great up to now, some of these panelists you're going to meet in part 2, like Vangelis Maragoudakis, our radiotherapy oncologist, who will be one of the major panelists in this part 2, along with Vangelis Carlos, who's also from Greece and he's radiotherapy oncologist. We're going to also have an excellent panel from abroad. But before we go there, we're going to introduce our oncologist, medical oncologist, which is Ilias Koteas from Greece and Vasilis Angelis from the United Kingdom. And finally, we have our breast surgeons, such as Mario Stasoulis from the United Kingdom, Andreas Karakatsanis from Sweden, Amit Agrawal from the United Kingdom. You have already met Thorsten Kohn in this part. He's going to have a major role, actually, from Germany. Giuseppe Catanuno from Italy. Unfortunately, he had somewhere to go urgently, and he'll probably be back with us in a while. And finally, Vasilis Karidakis from the United Kingdom. I guess we should all start with, we are only 14 minutes behind, so I would say 15 minutes behind. And I think we're fine with that. We're not going to cut our discussions because of these 15 minutes. I think we allow those 15 minutes. And Michalis, can you start with the first case?
Of course, 15 minutes is excellent for Greek standards, so let's move on. First topic is de-escalation of management of DCIS, and I'm very pleased and very honored to have Vasilis Karidakis, an old friend, a breast surgeon working in the UK, who will try to enlighten us on this. Vasilis, you have the microphone, the floor.
Good afternoon to everybody. Can you hear me?
Yes, we can.
Okay, thank you very much, Hellenic Society of Breast Surgeons, for inviting me to participate in this very important webinar. Thank you, Vasilis Venizelos, Michalis Kondos, Sophocles, Lanitis. Okay, so the second part of this webinar is about some critical decisions of borderline cases, diseases of breast cancer. DCIS is anyway a borderline disease. There is a question mark if it is breast cancer. We know that it is a pre-invasive breast cancer, and with very excellent prognosis. We know that the management and the treatment of DCIS has a standard schedule so far. All the surgeons do same things, but there is a big discussion if we can de-escalate this treatment and let's say omitting surgery, omitting radiotherapy, omitting or reduce endocrine treatment. As I told you, it's the most common pre-invasive breast cancer, and despite any treatment, some cases, 5 to 10% of DCIS cases, develop subsequent invasive disease. From the other side, there are some cases, and it is a big group that will never progress to invasive disease. And this is the group with the low risk and the very excellent prognosis. There are clinical trials at the moment for treatment and the escalation of management. currently underway by omitting radiotherapy, decreasing endocrine treatment, or even omit surgery. The standard treatment so far of DCIS is to excise the tumor with a wide local excision or mastectomy, followed by radiotherapy in most of the cases, or endocrine treatment. The key to de-escalate the management is to identify the group who has very low risk, and so far we do over-treatment. So it is very important presenting these cases to have an interesting discussion. And after all this discussion with the panelists, which are top doctors who treat breast cancer, to have a very interesting answers. So the first case is a 49-year patient premenopausal with a B-cup-sized breast. She had a screening mammogram, and a screen detected a lesion in at right breast, 9 o'clock. There was an area with microcalcification, new microcalcifications, very small area, 0.5 centimeter. On clinical examination, there was no palpable lesion and nothing palpable in the axilla. She had a stereotactic vacuum-assisted biopsy, which showed that DCIS low-grade, DR positive. She has a not significant family history of breast cancer, and her past medical history was unremarkable. This lady has almost removed the area of microcalcification, so we re-excised the cavity area, the area of the previous biopsy. There was excision 2 centimeters. There was no residual DCIS. So the first question we have to discuss for this patient, and the most important, because we have already completed her surgery, we cannot change that. So this treatment, the surgical treatment, wide excision with good margin, I mean more than 2 millimeters, will followed by tamoxifen, 20 milligrams a day for 5 years, tamoxifen 5 milligrams a day for 3 years, aromatase inhibitors for 5 years, breast radiotherapy, tamoxifen 20 milligrams with radiotherapy, tamoxifen 5 milligrams, the baby tamoxifen, we have to discuss for that later with radiotherapy, aromatase inhibitor with radiotherapy on no adjuvant treatment. Can we vote, please? I cannot hear you, anybody.
Okay, we're thinking what to vote.
Okay, because I thought you would
Very
do
hard
a
thinking.
comment.
You can almost hear our brain, you know.
Okay. I thought
Yeah.
I thought Michalis, you would do a comment or something before voting.
I think we left enough time. Can we see the results, please? Okay. We have no further treatment, no adjuvant treatment winning by 1/3 of participants voting for it. I see. Let me see. I'll start from the surgeons. Dr. Kuhn, what do you think? We cannot hear you.
Okay, sorry, I was muted. Michalis, I was quite happy with the result because I also voted for number 8, no adjuvant treatment, because I think certainly you can discuss radiotherapy in every patient, but the effect will probably be very small. And regarding the endocrine treatment, we usually do not go for endocrine treatment for tamoxifen over 5 years because there's only a preventive effect of tamoxifen. There's no effect on invasive recurrences. So we are very, in general, we do not go for tamoxifen. So probably, although, as you correctly said, patients with DCIS in general are candidates for radiotherapy because it decreases recurrences by 50%. But if the absolute risk is very, very low, then the relative risk of 50% risk reduction will not translate in any relevant reduction. So I voted for 8.
Thank you. I think I'd like to hear one more surgeon. Dr. Tassoulis, are you with us?
Yeah,
Hi, Marios.
hi. So, like Dr. Ken, I also voted for number 8, no adjuvant treatment. Again, I would like to stress out that yes, radiotherapy can be discussed. We know it can reduce the risk of recurrence, but the potential benefit in terms of survival not very clear. We do not tend to give endocrine therapy for women who have DCIS only, unless very young, high-grade DCIS. And again, that's mainly for risk reduction, not for the effect for invasive disease-free survival. So again, my thoughts are for this patient with a very small area or completely excised with a vacuum biopsy and low-grade DCIS, I would not recommend anything further in terms of treatment.
Thank you. Dr. Maragoudakis, are you happy with omission of radiotherapy?
I am surprisingly happy because I couldn't expect such a good answer. Actually, I don't see any reason to give either tamoxifen or radiation therapy because the possibility to have a bad process after this characteristic is very low. So what I would recommend is no further treatment, but close follow-up of the lady.
Thank you. Very well done. Should we move on?
Can I ask something? Michalis,
Yes?
yeah, if we give any kind of endocrine treatment, I would like to have some answer. Which one we would...
Absolutely. You are right. You are right. And we have, is Dr. Koteas with us?
Yes, good day to you all. We
Yes.
must always bear in mind that these options do not offer a survival benefit. Okay,
Yeah,
so I think here this in situ carcinoma is very low risk. I will agree with all the previous speakers. I won't opt for any kind of further treatment here. So.
Does anybody believe that in the 20th webinar, this webinar in 20 years' time, we will vote that no surgery is needed and the vacuum-assisted excision will be enough? Or even before 20 years' time, I don't know, next year perhaps?
I'm not sure about next year, but once we have the results from all the clinical trials, LORIS, COMET, and LORD, we might be able to answer this question. So hopefully, the next 5 years, I think COMET has already completed recruitment. So suppose in the next 5 years, we will have some preliminary results to support this, potentially.
But COMET is about totally omitting surgery.
Yes.
Okay.
But they are liberal to give endocrine therapy, though, because that's a US study.
Okay.
I think the only problem with vacuum-assisted excision, of course, will be effective, but we won't have any information for margins, which sometimes is important.
Okay. Thank you.
Okay.
I think you are right. I think you are right, Vasilis. So will be still useful. I know that many people want to say their opinion, but I think we should move on because we'll have to the chance to discuss about DCIS again. So Vasilis, do you want to move on to the next one?
Oh, sorry, just a moment to go back. So the second case is a 58-year-old patient, postmenopausal. She had, again, screen detected. All these cases are screen detected, no palpable lesions. She had the right breast screen detected findings, 3 areas of microcalcifications. First was 25 millimeter at 10 o'clock far from the nipple. Second lesion 10 millimeter and third lesion 5 millimeter, both central area. The nearest 20 millimeter distance from the nipple areola complex. She had a previous normal mammogram, but many years before. On clinical examination, has a C-cup breast size, nodular breast, no palpable axillary nodes. Ultrasound scan was not unremarkable in breast and axilla. She underwent a stereotactic vacuum-assisted excision of 3 areas, which showed high-grade DCIS, ER positive. This lady has no family history. This is the mammogram. I don't know if it is very clear, but you see 2 areas of microcalcification biopsy that are at the central part of the breast. The third area is in the lateral part of the breast, so we could say multicentric. The first question is, MRI scan is important for patient management and treatment? Yes or no? Can we vote, please?
So we have an DCIS, which is easily seen, relatively easily seen on mammogram. Do we need the extra help of MRI, and does MRI help at all?
Can we vote, please?
Okay, so should we see the results? It's a 50-year-old patient. Results, please. Okay, most of us voted for MRI, breast MRI. Can I ask Dr. Agrawal, what do you believe, Amit? Did you vote for MRI or no? What is the cost?
Hi, Michaelis. Hi, everybody. Yes, I did vote for yes. The reasons being, in fact, we published a review article about 2-3 years ago looking at MRI role in high-grade DCIS, mostly from planning surgical perspective. The conclusion, as probably majority of us know, it does not decrease the mastectomy rate, but possibly it does help in planning of surgery. I mean, looking at the case just presented, she does have a relatively denser breast. So if I was doing something fancy oncoplastic, I would want MRI scan. It does. In fact, we followed on with an original study from a center. We do have a high MRI scan because of multiple MRI trials. Now, we found slightly lower reoperation rates, not significant, but certainly it did help with planning of surgery. But I would like to hear counter argument. Thank you.
Before we go into the counter argument, so you think that MRI will identify further areas of concern, that further areas that need to be removed? Is that right? To map out the breast?
Yeah, correct. Because what we are seeing on mammogram, there may be some non-mass enhancements. Of course, we are talking of high-grade DCIS. It's not very helpful in low-grade DCIS, maybe in intermediate grade. So we do have like comet tail appearance, non-mass enhancement around what we have seen on mammogram, and and we do find, when we end up doing the vacuum biopsy, for example, if the lesion is there, and if we were to biopsy the opposite end of the MRI identified enhancement, often we find tail of DCIS tracking, which possibly explains why there's higher mastectomy rates. But flip side of argument is, of course, it's identifying rather than leading to positive margin rates.
Thorsten, would you ask for an MRI in the MDT?
Well, probably we would not, although I understand the discussion and the argument. I think we should discuss. The first question is, this is a multicentric disease, or multifocal, multicentric, we should discuss whether we opt for primary mastectomy with reconstruction or whether we opt for breast conserving therapy, which may be an option for me. But if I go for mastectomy, I certainly do not need an MRI. There may be some advantages, I agree, and there's some literature showing advantages in high-grade DCIS. I agree as well, but probably we would not go for MRI in Germany because we think the benefit is quite small. And then I think, but this will become a little bit later, the discussion is how we proceed for surgery. But the first question will be, do we go for mastectomy or do we see the opportunity to still perform breast conserving therapy?
Thank you, Thorsten. I see that if you have planned to do a mastectomy, then MRI is not useful. Should we move on?
We
Was it-
totally agree. So, what is the plan for the surgical treatment? Breast conserving surgery with a kind of therapeutic mammoplasty, nipple sparing mastectomy with immediate reconstruction, skin sparing mastectomy with immediate reconstruction, simple mastectomy plus minus delayed reconstruction.
Okay, let's have the poll box, please, now. I guess this is if technically the breast conservation is feasible. So if you had the chance to conserve the breast, would you conserve the breast?
You ask me?
And let's see the results now, please.
Yeah.
Mm-hmm.
Right. So we are divided. We see that there's a lot of people opting for conservation, a significant number opting for a mastectomy and reconstruction. Right. Dr. Tassoulis, can we have your opinion? And what did you vote?
I voted for one, but I appreciate that it might be difficult, to give the right answer unless you have the patient in front of you to be able to fully assess them if they are suitable for breast conserving surgery with a mammoplasty procedure. So if this is technically feasible, and this is also what the patient would like to have, then I would definitely go for breast conserving surgery. We do have good quality data to suggest that it offers significant benefit, from physical, mental, psychological, well-being point of view, and also overall satisfaction with outcomes. So if breast conserving surgery is feasible, that would definitely be my top choice.
Thank you. I think it's a reasonable answer. Should we move on?
Yeah.
Maybe
Before we move on, we decided after discussion with the patient to go for nipple sparing mastectomy with immediate reconstruction. I remind you that the distance from the nipple was at least 2 centimeters.
maybe can I have one comment, because I think
Yeah.
Yes,
very-
absolutely.
Yeah, because I agree, absolutely, it's important to talk to the patient and to have a shared decision making. And you certainly have both options. Go for mastectomy. In case of breast conserving therapy, I think there were around 25% of the tissue involved, if I remember correctly, the mammogram. So what you always have to consider in such a case, if you go for breast conserving therapy, that the rate of re-excision is quite high, because with the calcification, in DCIS, you often overlook microscopic disease. So what I often do, so if the breast had a site where you could go for, let's say, a kind of reduction technique, what I sometimes do, if I see there is a relevant probability of having re-excision, then I do a two-step procedure, but I have to discuss this with the patient. And in the first step, just take out the target volume, then go for histology, and then do my reconstructive technique in order to avoid re-excision in a breast that then is very difficult to do surgery on. So this is a two-step strategy that I often perform in such cases.
Thank you. Amit, you want to say something,
Ah,
but you
sorry.
have to keep it short.
Yeah, basically, I agree with Dr. Kuhn. The only thing probably I would have added to confuse the patient further is add the option of partial breast reconstruction with chest wall perforator flap. And very similar to what Dr. Kuhn just mentioned, because there is multifocality of DCIS, would have done in 2 stages, do wide local excision,
Yeah.
leave some water in the cavity and come back and do reconstruction.
Thank you. Vasilis, let's move on.
Yeah, I agree that the final decision of us for this patient was because the patient at the end wanted to have mastectomy. And also, after all these fancy procedures with reconstruction, not reconstruction, the mammoplasties, the problem is if the histopathology come back with positive margin or close margin. It is sometimes difficult, you have to do more procedures. Okay, so the next question is, we did mastectomy. What is the auxiliary operation in case of mastectomy? Sentinel node biopsy up front, use of supraparamagnetic iron oxide SPIO to do sentinel node biopsy in a second setting if necessary, or no auxiliary operation necessary if in the ultrasound scan we had normal lymph nodes.
So perhaps we need to clarify what number 2 means. It means that we inject the SPIO, we
Yes.
don't remove any nodes.
Yes,
and
yes.
if we need to remove any nodes in the future after the histopathology report comes back, for example, invasion, etc., we go back and remove the sentinel node then.
Yes,
So-
but most of the times of these cases, we avoid to do the second operation. So it's a very good choice, the second one. And yeah,
So let's vote.
let's vote.
Okay, and let's have the answers now, the results. So most of us voted 1 or 2, so we wouldn't do nothing to the axilla. Thorsten?
Yeah. So I voted for 2, but this is certainly due to the fact that I have the SPIO technique available. And this may be a reason why many people also voted for solution 1, because the machine is simply not available. But I agree entirely that the use of SPIO is excellent for patients who undergo mastectomy, because the large majority will be node negative in the end. And so you can avoid any axillary procedure in this patient. And for those who have invasive disease, you can go for a second operation and do the staging later.
Okay, I think both options 1 and 2 are very reasonable. Okay, Vasilis, let's
Maybe-
move.
Maybe
remind you that-
Andreas has a comment, Karakatsanis, because I think is
Where is it?
supposed.
He's not with us. He has a lecture. He's going to be later on in, but we
Okay,
can ask him
okay,
later on.
okay.
I just
Sorry.
I just want to see that everything works. Yeah, thank you for this option. This is how we do things. We still do the second part of the Sentinel trial, which is a randomized trial. I know that there are a lot of people that have moved in doing this upfront. Yes, the numbers look very promising. It looks very safe. The final trial results will give us the evidence needed to support that on the level of guidelines in the future. Interestingly, a comment is that oncoplastic breast conservation is the same exact situation with a mastectomy. So extensive remodeling of the tissue, or putting a flap in the middle or doing a big reduction, usually leads us to fail sentinel lymph node detection afterwards, and then SPIO can also be considered. I will be back to you in some minutes. Okay.
Thank
Okay,
you.
thank you, Andreas.
Vasilis, before we go on, I have to say that we have 8 minutes to finish this presentation.
Okay,
It's not feasible,
yeah.
but at least let's try to
Yeah, we'll try and we'll finish. So we finished with surgery. Does this patient need adjuvant treatment after mastectomy? Aromatase inhibitor or tamoxifen for 5 years, radiotherapy, both of them, or no adjuvant treatment?
Let's vote, please. Okay, let's see the results. Oops. So most of us voted for medication, voted for endocrine treatment, and the second is no adjuvant treatment. I want to ask Dr. Angelis whether what is his opinion?
Hello, everyone. So clearly, this is not something we tend to see as medical oncologists in the UK. But from my experience, from my colleagues in the clinical oncologists, we don't tend to use endocrine therapy unless patients are not fit for radiotherapy. And if that in that case, we might use 5 years of tamoxifen. But in most cases, I think what their criteria usually is the grade of the DCIS and whether there's any necrosis present. So in very few cases, I think I have seen this being done in a way that they give radiotherapy followed by endocrine therapy. That's my experience.
So what she's had a mastectomy. I'm playing the devil's advocate now. So she's had a mastectomy. Why would you give her this tamoxifen or AIs? What the benefit from it?
Again, it's more like prophylaxis really than actually treatment, but we don't tend to.
Is it for the other side?
Yeah.
I mean, you know, there's some evidence about this, but it's not adequate. I think generally we avoid using endocrine therapy in this setting, and we leave it to the clinical oncologist to offer radiotherapy if indicated.
Okay. But would you agree that the benefit, if there's a benefit, will not be huge?
It won't be huge, and I guess the reality you have to account the toxicities of these drugs and the duration they're going to be given. So, you know, you could potentially have a discussion with the patient and explain and see if there's any other potential risks or comorbidities that may be an issue for. And if we decide, you know, jointly to go ahead and do this, then in essence, you would have a low threshold in stopping this.
Dr. Carlos, what is your opinion on radiotherapy? I know the answer, but you know, I know your answer.
It's a multifocal high. First of all, I would like to thank Hellenic Society of Breast Surgeons, especially Professor Kondos, Dr. Lanitis, and Dr. Venizelos. It's a multifocal high-grade DCIS with a mastectomy, so I didn't suggest radiotherapy in this case.
Yeah, it's straightforward, this one. All right, I think we should move on, Vasilis. Next case.
If we did not, in this case, if we have done this type of breast conserving surgery, we would give endocrine treatment, radiotherapy, both, or no adjuvant treatment.
So this is a question to. So sorry, Vasilis. What?
If in this case, the previous case, the case with multifocal, multicentric, we have decided to do breast conserving surgery.
Yeah.
The adjuvant treatment would be different. We would offer radiotherapy probably.
Radiotherapy, Panteli.
Yes, of course. If is breast conserving surgery, I suggest to do radiotherapy this patient with a multifocal high-grade DCIS.
And where would we stand?
Just in the breast.
Yeah.
All right. Should we move on, Vasilis?
Okay, so no voting for that.
No voting because there's no, yeah.
Okay. So next case is a 65-year-old patient, had previously intermediate grade DCIS, 10 mm treated with white local excision, radiotherapy, endocrine treatment for 5 years. That was 8 years before this new findings, new mammographic finding, 1 centimeter area of suspicious microcalcifications, 4 centimeter from previous surgery, good skin quality if there is any question, vacuum-assisted excision biopsy, DCIS intermediate grade, ER positive. So treatment, new breast conserving surgery, of course, after localization, mastectomy, radiotherapy, different endocrine treatment, surgery, breast conserving surgery with radiotherapy, breast conserving surgery with different endocrine treatment, breast conserving surgery, radiotherapy, and endocrine treatment, or only radiotherapy and different endocrine treatment without any surgery.
Let's vote. Yeah. And let's have the results now, please. Okay, most of us voted for mastectomy. I guess they did not want to redo a lumpectomy in a breast which has been treated before. Let me start. Amit, what did you vote?
Well, I have to say this is a difficult one, but I did vote for breast conserving surgery, but I would have preferred maybe choices. She had previous high-grade DCIS, didn't she? And this is intermediate grade DCIS. So what I was thinking, her prognosis is pretty much decided by the previous pathology rather than what's happening now. Having said that, if we were to discuss with the patient, of course, it's a recurrence. Recurrence is always a bit of a downhill psychologically. So yeah, I'd probably put on equal footing mastectomy as well.
But let me just clarify, breast conservation is not a no-no for you.
Not a no-no.
Okay. Let me ask, I can see Pantelis Carlos. Is Vangelis Maragoudakis with us?
Yes, I am.
Hello, would you be happy, Vangelis, to re-irradiate this breast?
Yes, as partial breast irradiation, it seems not to be a problem. Now I would discuss with the lady, and if she has a strong desire to keep the breast, then I would recommend number 7, so that we will have breast conservation plus partial radiation and changing the endocrine treatment. Otherwise, mastectomy seems to be the most the best solution from the point of disease, decreasing the possibility of recurrence.
Thank you. Elias, Dr. Koteas or Prof. Koteas, would you like to share your opinion with us?
Well, I'm not a surgeon, not even a radiation oncologist, but
would you change would you give her endocrine treatment? Would you change it?
Well, I think there is a 3-year period since the cessation of the endocrine treatment until the appearance of a new lesion. I'm not sure that means that this woman is endocrine resistant. Okay, patient is not I don't think she's an endocrine resistant patient. So maybe not. I would continue the same treatment that she had before, depending on the toxicities. Maybe this is a good reason to change endocrine toxicity, the underlying toxicity, not the biology. Yeah.
Okay. Sophocles, should we move on to the last one or skip the last one? It's one more case from Vasilis.
Just,
I think
it is very quick.
We're quite behind, but if it's going to happen in 5 minutes, 3 minutes, maybe we can do that. But we
just it is a very quick. Just I would like to ask the panelist about this new oncotype for DCIS or decision radiotherapy score. If we use that, because there are some trials. So 62-year-old patient, left breast screen detected 0.8 centimeter area of microcalcifications. She had stereotactic vacuum-assisted biopsy, which showed low-grade DCIS, ER positive. On clinical examination, no palpable abnormality, neither breast and axilla. So that's the area after. Plan for surgical treatment, breast conserving surgery, wide local excision after localization, no surgery, first question. Low grade DCIS, 0.8 centimeter.
So let me. Okay. Let's see the results now, please. Quite straightforward. Everybody would go for
The
for
standard
surgery.
treatment.
Yes, standard. Okay, let's move
And
on.
the next one, radiotherapy, endocrine treatment, both of them, no adjuvant treatment, only surveillance, just to close them.
And let's see the results. Okay, so most of us decided not to do anything else with this patient because apparently of its indolent nature.
Yeah.
I would like to hear Kostas Zachariadakis.
Sorry, but it's half here. Half of the dentists would do nothing, and the other half would do something. Whether that was a combination or just one, it's still something. So 50%, I think, is a traditional way, and 50% is the
Something else. Yes, I agree.
something else.
Will we have in the future this test, molecular test, genomic test to decide in these cases with a low risk cancer? That's my question. If
Does anybody have any insight on this?
May I talk? This is Vangelis Maragudakis.
Yes, of course.
The two parameters that we should evaluate is first how clear the margins are. I mean, it's different if it is 2 millimeter or 8 millimeter. And the other parameter is what kind of normal breast tissue do we have? I mean, if we have flat epithelial atypia or other aspects that have increased possibility to have a recurrence, that should be taken in evaluation for the final decision.
Pantelis?
As we mentioned, irradiation decreased the risk of local recurrence in DCIS around 50 or 60% approximately. In this case, we have a low-grade DCIS, so we can avoid radiotherapy. We have some tools like DCIS decision that take in contact not only the immunochemistry grade necrosis margin, but also the gene expression. But for now, at least in our center, we don't use the DCIS decision yet to make the decision if we can avoid our radiotherapy. But in this case, we can do close follow-up, I think.
And final comment. Thank you, Pantelis. Thorsten, you have raised your hand.
Yeah, I agree. So we do not use the DCI score, but what I think is an excellent tool to discuss individually with the patient is a nomogram from the Memorial Sloan Kettering. You can enter some points, and it gives you the 5 and 10-year recurrence rate with and without radiotherapy. And I think this is an excellent tool that you can use in 2 minutes to calculate the risk score. And it's very helpful in clinical routine.
Thank you. Right, thank you, Vasilis. This was the last one, I guess. Yes.
Thank you very much.
Thank you, Vasilis. DCIS is always difficult. It's an early type of breast cancer. and certainly we don't want to over treat it. Thank
Well,
you.
but
very
Michalis,
much.
but it was nice to hear that most people believe that we have to de-escalate the management of DCIS. And if I'm not mistaken, it's the first time in the NCCN guidelines they have the addition of observation only. I think it's the first time I've seen in the NCCN guidelines having only observation, no further treatment for DCIS. So I think we're heading that direction, although it took us about 100 years to reach that level for
course.
such a benign
You're right. You're
progress
right.
disease.
You're
Okay, shall we
right.
carry on?
Yes, we should.
So we have the privilege to call Amit Agrawal to talk us about something really interesting. How do we manage, or how do we de-escalate the management or escalate the management in elderly patients? But initially, what is the elderly patient? Amit, would you mind taking the floor and let us know what is an elderly patient?
Thank you. Let me just share my screen. Can you see everything? Can you see my screen?
Yes,
Yep.
yes, we can.
Okay. Thank you, Dr. Venizelos, Dr. Lanitis, and Dr. Pontus for inviting me. It's a pleasure to be here. Yes, elderly breast cancer. So the first question that I would have for the panel, there's no voting for it. I don't have any conflict of interest. What's the politically correct definition now? Should we be calling elderly breast cancer or cancer of the older woman? Probably I'll target Michalis for your comment.
As you're muted.
It's not voting yet, sorry.
It's not voting, so let's not vote. So you asked me what I consider an elderly patient. Well, I don't know. And I have to add to this that elderly people 20 years ago are different than elderly people today. And all the trials on elderly people we have are based on elderly people of 20 years ago. So the answer is not, I don't know. And age is not calculated or measured in years, but rather on how the biology of the patient is. So I don't have any answers, Amit. I'm sorry.
Shall we see what people
Well, that's-
believe
that's-
about the age? Shall we vote, Amit, on this
Exactly.
one? Let's see.
Yeah, that was the prelude.
Okay, so
80 years old. Wow.
Okay, that's more than 70, which is what most of the literature does allude to, certainly in the literature coming from the UK. So over 70, that's about 39%. And the remaining 39%, the next equal footing is age-independent fitness. And that's where, Michalis, you set the tone that we should be measuring disease in terms of the age-related fitness for the patients. And the other point which I wanted to make, the politically correct term, it seems nowadays, is cancer of the older woman as opposed to elderly breast cancer. And that's been voted by a panel of older women who are part of the Patient Public Initiative group in the Geriatric Society of Oncology. So that's why my slides will say cancer of the older women rather than elderly breast cancer. Now, when you look in the literature, certainly there is literature including over 55 as well. But I think we are moving towards option number 5 from option number 2. Does the panel agree? I can't see the whole panel, so maybe
there's no question, so we can carry on. Amit, we can carry on.
I guess just a quick note is that it depends where you practice and how the prevention population is, because we have a lot of patients that are actually younger than 55, but they have multiple comorbidities, mostly because of social background, late presentations. And we incorporate these patients in this group sometimes because they can have extensive, poorly managed comorbidities.
So,
Okay.
Dr. Angelis, is there a definition about who to call older or no older? Apparently,
don't
you know,
actually
it's a
use-
biological age, but
Yeah,
in
we
the
don't actually
studies you have to
use,
include some.
Yeah, I mean, clearly we have geriatric oncology services running along with us, but at the same time, we don't actually have a definition that we label a patient as being elderly. We discuss each case as they are.
So it's age dependent fitness. This is the answer, the correct answer.
Yeah.
Okay, let's carry on.
And
Carry
there
on.
are couple of tools that people are might be using. One is Charlson comorbidity index, but that's not very breast specific. All it does is puts the age and the comorbidities together and gives a 10-year survival kind of prediction. But in the UK, there's an increasing use of age gap tool, which includes the age comorbidity, the frailty of the patient, something like whether they can dress themselves, can they, move about easily, and it also takes into tumor features. So I'm going to be giving some example later on. So the first case is somebody I saw in 2018, age 74, fit 74. With a body mass index of 22, she had 3 centimeters, so T2, grade 3, no special type of cancer, triple negative. Majority of the over 70s are ER positive, but this is where about 15%, I guess, are about triple negative. There was no DCIS, but one node was positive on core needle biopsy. So there's T2N1, no metastasis, but we don't do CT staging unless it's more than T3 or more than 4 nodes appearing on initial ultrasound. So what would be the first step people would want to do? Do we vote or discuss first and vote?
No. We vote and then we discuss the answers.
Okay.
So shall we vote? Let's see the poll, please.
Please, thank you.
Okay.
Am I allowed to vote?
Yes. Of course, you're allowed to vote.
Okay.
Okay, can we see the results, please? So most people voted in favor of neoadjuvant chemotherapy, followed by surgery and radiotherapy. And Mr. Tasoulis, can you comment on that?
Yes, I voted for 1, really, because I think that would be the standard based on the presentation in biology. But then this is a discussion, to have at the with the patient and the multidisciplinary meeting to assess the individual patient fitness for chemotherapy, and then discuss with patients where are in terms of priorities, whether they would like to have a toxic treatment with side effects, or whether they would like to have a more simple treatment plan, but with a potential, risk in terms of the overall outcome. But this would have to be a balanced discussion between us, the patients, and then the rest of the multidisciplinary team. But I voted for 1.
Does any of the oncologists want to say something? Mr. Vatias or Mr. Angelis?
Just a quick note that our current trials that would support using neoadjuvant included patients similar to that age. So Keynote 522 had an average median age, of 49, but there were patients up to 80. So I think depending on fitness, we would consider neoadjuvant treatment with or without pembrolizumab. We'll discuss this later.
Amit, do you have any else that you want to talk, or shall we move on?
Well, the only comment I would make, because I refer to the age gap tool. So when I put this into the age gap tool, what it showed me, the survival, if it was surgery, only surgery including radiotherapy, was 54.4%, 5 years, and surgery with chemotherapy was 58.9%. So it's about 5% difference between the survival, but that's the age gap tool. So yeah, we can move on to the next. So she did, our team recommended neoadjuvant chemotherapy. Now, I think our medical oncology colleague kind of hinted at something just now, but I would like the audience to vote, and then we can discuss which regime would we want to give? Can we vote now?
Yes, let's give them some time because quite complicated for surgeons to interpret all these details and data.
So basically, to simplify, option number 1 is weekly paclitaxel, which MedOnc may comment later, with 3 weekly carboplatin 4 cycles, followed by epirubicin and cyclophosphamide, along with pembrolizumab. Option 2, if the patient was less fit than what she is, she would probably skip pembrolizumab. And if she was even lesser fit, skipping pembro and EC. And if she was really a bit, least fit, perhaps just weekly paclitaxel for 12 weeks, assuming that the patient is fit for some chemo. How would people
Okay,
vote?
shall we see the results? Okay, split between 1 and 2. Ilias?
So, yes, we have to take into account that approximately 90% of patients enrolled in the Keynote 5.2 trial were 65 years of age younger. So only 10% of patients were older than 65 years of age. So I think that this is a 5-drug regimen, not fit for everyone. So I would opt for a anthracycline-free or a carbo-free regimen for this woman, depending how fit she is.
Okay, and Dr. Argelis?
I kind of beg to disagree on this because we tend to start with the paclitaxel carboplatin anyway. I think the question here is whether we feel the patient is fit for pembrolizumab as well. In that case, we would start all 3 of them. And then if we decide that we go ahead, what we tend to do sometimes for certain patients that we think may experience certain toxicities is we may stop after they complete this part of the regimen and skip EC or AC completely. So I think the question here is that you have to define whether your patient is fit for chemotherapy to start with. So I would never probably do 4. If you think they're not fit, then they should go to surgery directly. Having weekly paclitaxel, I'm not sure it's going to offer any significant benefit here. So the question is whether you think she's fit for pembrolizumab NAC or not. And if that is the case, you go ahead. And if you've realized that they're not tolerating this well after having the first part of their treatment, then you proceed to surgery and you skip AC. The issue here is that if you think they're fit enough, then the point of giving pembrolizumab is you get a better response, and there's a higher chance that you will get a complete pathological response if you include that. But equally, you have to weigh the potential risks and the benefits.
Hey, Hamid, are you happy with the answers? Or
Yes, certainly. Just to put in the perspective, would we do BRCA gene mutation testing in 74? Would that make a difference to the MedOnc plan? Over to MedOncs again.
So our general guidelines for mainstream genetic testing in the UK is that patients above 60 are not tested. In reality, because there's a very small chance that they're BRCA carriers. Now we do carry a study at the moment called BRCA Direct in collaboration with, and I'm sure Marius knows this, with Royal Marsden, that we're basically testing every patient with diagnosis of breast cancer within 1 year, because we might, pick up some patients that they do. In reality, for this lady, and we can argue about this, because of her age, I don't know whether it would be worth discussing prophylactic surgery if she was ever a BRCA carrier, but what she would potentially access is access to adjuvant PARP inhibitor if she doesn't respond very well if she was a BRCA carrier.
okay, thank you very much.
Yeah.
Hamid, can we carry on?
Certainly. Yeah. So this patient had option number 2 because there was no pembro in 2018. She did get 3 cycles of carboplatin and literally the first cycle of cyclo, and then she could not tolerate. So we ended up doing MRI scan. We tend to do MRI scan initially and halfway through and towards the end before surgery unless we decide for mastectomy upfront based on DCIS or other things. So she had 24 millimeter of tumor left on imaging, so kind of imaging partial response. And axilla on ultrasound and MRI, we were not sure what was going on. She was one node positive, if you remember, before chemotherapy, and now end of chemotherapy, we were not sure what was their status. So number one question, which probably, would be in the minds, I haven't got the voting, is whether the panel would be happy having the patient choice, because 24 millimeters, she could have wide local or mastectomy. I think there's strong, probably if we were to vote, majority would vote for wide local excision because there's 24 millimeter tumor. So that's why I haven't got the vote. But what do we do with the axilla when there's a equivocal response and imaging, partial response in the breast? What do we do?
And we have the
Sentinel
poll.
node biopsy. Yeah.
So what we do in 2024, we have already heard a couple of
Yes.
things in part one.
Yeah.
I think before we get the results, Thorsten will be the one to discuss this answer, I guess. Thorsten.
Okay, I agree with the majority to go for target axis resection if the node was marked. And if the node was not marked, I would also be happy with a central lymph node biopsy alone. I think we have to consider that any axillary surgery is a staging procedure. And in this patient, the result from the axillary intervention will not impact systemic treatment or radiotherapy, because the systemic treatment is determined and regional therapy is determined. So it only impacts surgery to go for axillary resection or not in case of positive nodes. So I would definitely go for less invasive surgery.
Okay, thank you very much, Thorsten. I thought it was your answer. That's why I asked you to discuss. Anybody else from the surgeons wants to say something different, or shall we carry on? I mean, anybody else that would have gone for something more aggressive in this lady? I guess. No. Okay. I can see your faces turning like the no sign. So Amit, carry on, because everybody agrees with Thorsten.
Okay. Right. So this particular patient, that was 2018, we didn't do targeted dissection, at least in my unit at that time. So she did have mastectomy. She opted to have mastectomy, and we did clearance. I think it was level 1 clearance, postoperative pathology as demonstrated. 42 millimeter was the final pathological size, although in imaging it appeared 24. Grade 3 triple negative, partial response, and 2 out of 14 nodes were still positive. So what do we do next? We can vote, we can discuss several things, I guess.
Amit, would you mind reading the answers? If you can read the answers for the audience to understand them. Yes, the question, the answers.
Definitely. The answers. So adjuvant therapy, now, because we have done axillary clearance, so in 2018, what would you do? Adjuvant capecitabine along with bisphosphonates and radiotherapy to the chest wall, or would you just give capecitabine and bisphosphonates, or would you just give bisphosphonates or just radiotherapy or do nothing? Because she had mastectomy and clearance and she did not tolerate chemotherapy. Can we vote now?
So we have the chance to vote. I think, and if we had a TAD or central lymph node biopsy, the axillary lymph node dissection would have been the outcome in this lady. And most likely with that big tumor, would have been something like that.
We could discuss that, I guess. Yeah. What would we do in 24?
So obviously this is a question for the oncologist. So let's see the results, and then we'll discuss, both of you, if you can, the results of this voting. Can we see the voting? Okay, most people voted for one. And I would like first Elias and then Mr. Angelis to talk about it.
Well, see, that's why this patient needs genetic testing. She was BRCA positive. She made may have a substantial benefit from adjuvant olaparib here, but there's no such information. In any case, we have residual disease, triple-negative residual disease after neoadjuvant chemotherapy. So I think the best option here is to combine capecitabine with bisphosphonates and also RT.
Dr. Angelis, what do you think? Agree with that?
Yes, I agree. I think in reality, one thing we might consider in this case is because the histology was not what we expected and more nodes seem to be appearing, is in some cases we think about staging for these patients. Yes, in this case, she would be eligible to go on adjuvant capecitabine, which is better tolerated, and bisphosphonates and radiotherapy. There's a lot of research activity in this field. We're currently participating in a number of trials that are looking at the use of antibody-drug conjugates in this field. So TROPION-3 is one of the studies that we're recruiting these patients, and despite the fact she's 72, she would be welcome to join. And in essence, that's looking at the comparison between capecitabine, which in this study, in essence, if she had pembrolizumab, we would combine it with, versus the use of antibody-drug conjugates combined with or without immunotherapy. So yes, one, I think, is the option for this lady.
Before we move
So
on,
just-
Pantelis, would you mind giving us an insight about the radiotherapy in this case? What kind of radiotherapy would you give in this lady?
I prefer to. This patient after neoadjuvant treatment has a disease in her axilla. So I would suggest in this case to do not only the chest wall, but also the regional node irradiation, also with good techniques like deep inspiration techniques. So I wouldn't suggest only the chest wall. I would
Okay.
irradiate and the lymph nodes, the regional lymph nodes.
And Dr. Maragoudakis, what do you believe? Would you agree with Pantelis, or would you do something less than that?
Well, you have to evaluate the danger, the risk. I think that Pantelis is right, though we can omit radiotherapy to the axilla since we have excised 14 lymph nodes. If those lymph nodes were less than 10, then it would need radiotherapy for sure. Now we feel a little bit more confidence, but Pantelis' option is right.
Hey, thank you very much.
think
Amit,
that-
are you happy with the answers? Have we covered the thing?
Yeah,
of
yeah,
the...
I think that was the discussion, because of course we are giving adjuvant capecitabine based on CREATE-X trial data for the surgeons in the audience, and bisphosphonates. I think it's mostly coming from a ZEO trial and other meta-analysis. That's what we did. And regarding radiotherapy, yes, because there were 14 nodes and there were only 2 positive, although post-chemo positive, our oncologists were kind of okay with chest wall radiotherapy only. So we'll move on. So if we were to assume she had regional radiotherapy and she declined capecitabine but took bisphosphonates, and then she had chest wall recurrence, which she did, despite having, so what she had was she declined capecitabine, she had bisphosphonates, regional RT was, I think it was half what, it was chest wall with internal mammary. It was an SCF. I think that's what I point, because the tumor was more medial. So if she had chest wall recurrence, what do we do now, 4 years down the line? Surgery, number 1, capecitabine, or both?
Obviously, this patient
There
doesn't
was-
want to do well. So let's see what's the answers of the poll. Let's see the results.
And staging CT was negative, so there was no systemic metastasis.
So most people voted both, and 1/3 voted only surgery, and only a small percentage voted against doing something aggressive and giving only medication. We'll probably start with the surgeons, and I don't know, Thorsten, would you like to talk?
I think we talk about the recurrence. Is this correct?
Yes, it's a recurrence. It's a
Yeah.
recurrence. Yes.
No,
It's
I
a
think
local,
we could go
yeah.
for surgery and chemotherapy. And the reason is the CARLOS study that randomized patients with or without chemotherapy. And there was a significant benefit for patients undergoing chemotherapy for the EAP negatives. So the evidence is the CARLOS study.
Thank you very much. And somebody else from the surgeons want to say something? Elias, would you want to say something? You would like this patient to be operated before anything else, wouldn't you?
Yes, I would. I see that this patient declined capecitabine the first time, so I'm not sure she's going to have it now. So it doesn't seem to me very willing to receive further chemotherapy. So I think we have to proceed with surgery. Okay.
Okay, thank you very much. And another question that is not here, would we consider another radiotherapy in this patient? No, I guess she had enough. She had the whole dose. But Mr. Margoudakis, do you think there's a chance that this lady may have some more radiotherapy, or are we done with it? Are we done with you?
Well, that depends on how wide the excision is and how big the recurrence is. I mean, if we have wide margins, then perhaps we don't need radiotherapy. But if the margins are close, then it's a problem. Another option is if we have a flap to cover the operating area. I wouldn't be very pleased to irradiate the flap. So it depends on how big the recurrence is, how large the recurrence is, what are the margins, and what is the quality of the tissues that have already been irradiated. If I see that there are signs of stenosis, sclerosis, something like that, I would avoid it because of the danger of necrosis.
Thank you very much. I think we have covered the recurrence here. Amit, what do you think? Have we been okay with that?
Well, if I may ask the med-onc, so now it's 2022, would you have something else in your kit to give her, like Pembro, or would you want to do a TILS or PDL1, anything different now?
Rangelis?
There's no evidence of metastasis from what you said, so technically she's not metastatic. So we would not be doing PD-L1 testing in this case. But clearly there's signs that this is a very aggressive, ugly disease that appears after radiotherapy. So I think we would be keeping a close eye for her and kind of doing, I would recommending in this case to do scans every 3 months to see if we can detect any disease. But I think at this point, we would not treat this because the evidence for TILS is not in recurrence, is in primary cancers.
Thank you. Can I move on?
Yeah, definitely.
Yeah, so it was a wide area of recurrence. So, and as you can see, she's very low BMI to start with. So I did a thoracodorsal artery perforator flap-based chest wall cover without any muscle. But then the margins were positive. So what you can see, a little triangle next to the drain tube. So this is second surgery. First on your left is the Tdap cover. But then when the margins are positive, oncologists wanted clear margins fair enough. So went back and did lifted the flap and took a bit more. So that's the surgical fancy bit. But unfortunately, as our med-onc colleague just mentioned, sorry, I'm not very clear with names at the moment. It is an ugly disease. It was an ugly disease. She developed recurrence within months, and it pretty much recurrence occupied whole of the chest wall on that side, and she developed lung and liver metastasis and passed away. So
well, it did seem from the beginning like a good disease. Yeah, it didn't seem a good disease from the beginning, wasn't it? I mean, it looked like it wouldn't do well. Yeah. Okay, so even the older ladies are getting aggressive disease, huh? Usually they don't get that aggressive disease, the old ones. Okay, shall we carry on? Yes, let's carry on to the next one.
Yeah. Okay, so the next one is a bit of a different take. Again, older woman, but ER positive. So a bit of a sigh of relief. 79 years old, but locally advanced surgically seemed operable, larger breast but locally advanced tumor, hypertension, bit of cholesterol, type 2 diabetes, but well controlled, lives alone, independent, grade 2 ER positive, strongly positive, progesterone receptor strongly positive, HER2 negative. We don't do Ki67. Node was negative on pre kind of a diagnosis. So she was clinically T3 and not M0. We did CT staging. So what will be the best first treatment for this lady? 79 years old, independent. Neoadjuvant chemotherapy, option number 1. Option number 2, neoadjuvant endocrine therapy. Number 3, neoadjuvant endocrine combined with CDK4/6 inhibitors. Number 4, neoadjuvant radiotherapy because she was locally advanced fungating. And number 5, we do upfront surgery, mastectomy and clearance, or we do mastectomy but with sentinel node because the node was negative. Can we vote now?
Okay, shall we see the results, please?
Okay.
So we most of the people
Interesting.
voted in upfront surgery. 53% is upfront surgery. So obviously a surgeon should speak first. Mr. Tasoulis.
I voted for 6, although I'm generally speaking always in favor of neoadjuvant systemic therapy if that's an option. But she's 79, has comorbidities. We have to consider what is the expected response to treatment. And so it would be extremely unlikely for her to get a PAT-CR with this tumor biology. So the question would be really if we could downsize the disease and convert something that would be mastectomy to breast conserving surgery. So at that point, we would have to discuss with the patients and check what the priorities are. But I think that would be my decision-making process. And for this lady, probably I would offer upfront surgery, remove the cancer, stage the axilla, give more information to the medical oncology team to decide what comes next.
Okay, I would like to ask somebody, would somebody consider neoadjuvant endocrine treatment before surgery? Does anybody wants to support this one?
I
Yes.
think Ash Kotari wants to say something. Ash, are you with us?
Hi,
Because
yes. So
Hi.
I wanted to say something previously. Hi, thank you. And thank you for having me. No, I agree with Marios. I think unless this patient wants to have breast conserving surgery, neoadjuvant endocrine therapy, again, the question would be, you would give her NAET, agreed how long, what size tumor, and then if she has a complete response or she continues to have a response, would you then intervene or you wait for progression before you come in? So I think that's a long discussion that you need to have with the patient. And I agree with Marios, unless we are downstaging this to breast conserving surgery, the easy complete pathological response in half an hour is upfront surgery, mastectomy, sentinel node biopsy, and then NAET with CDK4/6. I mean, then ET with CDK4/6 and radiotherapy if oncologists feel. But I don't think NAET in this case is going to add anything in terms of benefit for this patient.
Do the oncologists agree with that? Would they consider us going first? Or would they consider any other option?
I think the key here is whether the surgeons think this is operable or not. If it was inoperable, then we would consider giving endocrine therapy together with a CDK4/6 inhibitor for this population. So neoadjuvant chemotherapy would be extremely difficult and probably not advised. And you know, with her histological features, it's unlikely she would get a great response as well. But you know, I would be keen to be guided by the surgeons. But as you hear, I think upfront surgery is what in most cases would happen. But I have had patients where we offered them neoadjuvant endocrine therapy with a CDK4/6 inhibitor because they were inoperable. And they actually had a very good response. Did that change the surgical plan? No. Was that the right thing for the patient? Probably, depending on the fitness levels. And that gave him a bit more time to prep for surgery. But having upfront surgery for this patient would probably with their features, give them a chance of accessing a CDK4/6 inhibitor in the adjuvant setting as well, probably.
Okay,
So
thank you.
for-
Elias, do you agree with that?
Yeah, so for Chris, yes, I agree with that. So I think, as I heard, she's fit and she's a resectable disease. I would preserve the option for neoadjuvant endocrine therapy if I knew the Ki-67 value. I'm thinking I would preserve these options for Ki-67 less than 20%. We don't know, but I think upfront surgery is the best option here.
Okay,
Sophocles,
yes.
can I intervene for 1 second?
Of course you can, yes.
I would like to hear Thorsten's opinion on whether he would agree with a sentinel node biopsy on a patient with a fungating mass, first, and second, in case the technetium, etc., does not work, or the SPIO does not work, what would we do in this case?
Thank you, Michael. This is really a very important question. So I think for me, certainly Ki-67 would be important. And fortunately, we have this factor available. So honestly, I voted for the neoadjuvant endocrine treatment to just let the tumor shrink. But I also agree that the operability is certainly an important factor. So everything depends. So this patient will undergo an operation somehow, but you may pre-treat it with the endocrine treatment, but this depends largely on the on Ki-67, and there is the probability to response to endocrine. For the central lymph node biopsy, this is exactly what I asked myself. Should this patient have an axillary staging? So I would discuss this primarily with my in our tumor board, because certainly it will not impact the systemic treatment. And again, axillary surgery is nothing else but staging. So as a staging procedure, it has to determine some kind of adjuvant treatment. It may impact radiotherapy. So I would discuss with my radiation oncologist if, in case of positive central lymph node, he or she would do regional irradiation. If not, central lymph node biopsy was not indicated.
Sophocles, may
Thank you. Yes, a short comment, definitely.
Yes, this is Vangelis Maragoudakis. First of all, it's the third time that I hear this webinar that we have to think preoperative chemotherapy or any kind of therapy for less operation. And especially for a lady who is almost 80 years, this is not the first priority. To my mind, we perform preoperative, any kind of preoperative treatment for the occult disseminated disease, or to have an answer about complete or partial response for further pharmaceutic treatment, and not for less operation. On the other hand, I voted for upfront surgery with axillary lymph node resection and not sentinel node, because if we perform mastectomy and we have one positive sentinel node, then we have to give radiation. On the other hand, if we have a good sample of lymph nodes and only one or two involved, then we can avoid radiotherapy. So to my mind, we don't have to think of preoperative treatment, and we have to think for a wider inspection of the axilla.
It is a T4. Miguel, it's a T4, isn't it?
The local T3, I think.
Look,
T3.
well, it's fungating, so,
T3,
so
yeah.
if it is
Well,
a
it's
bit,
operable anyway.
there's a
Sorry to break the party, but we have to move on. We can be talking about this for ages, but I think we have to move on because the point is that if we can take it out, firstly, we have to take it out. And this is the point that we have to take from this patient and then follow with the further treatment. So finally.
So the final one question. She did have, because remember, she's independent and she lives alone. So upfront surgery in a fungating, she's not going to be ready. She needs more help. So we thought, well, while she gets help, why don't we put her on neoadjuvant endocrine therapy? Of course, we wish at that time we had Ki-67, but then do we go for 14% low or 20%? Ki-67 is not something pathologist. There's a consistency. I don't know whether there's any pathologist in the panel. If not, we can move on. She did have mastectomy and axillary node sampling, the good old pre-sentinel node biopsy, 9 centimeter of tumor, ER positive, HER2 negative, node 2 out of 7. Now, and this is what surgery she had. So she had fungating tumor and basically resected mastectomy, a bit of upper abdominal enhancement. So we could close the gap easily without much of a trouble post-operative. And the final second slide is what do we do now in terms of adjuvant therapy? 9 centimeter grade 2 ER positive, HER2 negative, 2 out of 7 nodes. Do we consider chemotherapy? It sounds like no. But number 2 choice is aromatase inhibitor with CDK4/6, radiotherapy, or a combination. Number 5 would be chemo with radiotherapy. Number 6 is AI only with radiotherapy. And number 7 is AI plus CDK plus radiotherapy.
Okay, let's vote. And then I would probably invite Ash to give us a final comment about that, just one comment, along with one of our oncologists before we move on to the next session. So I think if everybody's happy, let's see the result. Okay, so nobody voted for only chemotherapy and nobody voted for AI only. Most people wanted a combination, with most people, 66%, to prefer AI CD4K6 plus radiotherapy. I think mostly it's an oncology decision, this one. So Ash, would you like to talk? Shall we give the... Yeah.
I think you're right, it's an oncology decision, but I did vote for 7. As Amit said, she's independent. We want to keep her independent and we want to keep her feeling good about herself. So I think 3 and 4 combination would be keeping her independent, would give her the best local control and also offer her good systemic treatment.
Okay, thank you very
would
much.
the oncologist be happy giving CDK4/6 to 79 years old?
Yes.
Yes, we are. I mean, daily practice shown that it's quite safe to do this. Okay, so if this is an 80-year-old woman, I will never give chemotherapy, and I choose AI plus CDK, and I would like radiation oncologists to share us their input about the necessity of adding radiotherapy.
Vangelis, one final comment.
I vote the option 7, 3 and 4, radiotherapy, of course, big tumor, grade G2, and with node positive. So certainly I would like to do radiotherapy.
And would that be regional radiotherapy or what?
I would irradiate the level 3 and 4 and the chest wall.
Thank you very much.
That's what she had. CDK4/6 wasn't available when she was diagnosed talking a few years ago. So she did have AI and regional radiotherapy. And with that, I'd probably like to sign off, Sophocles, if it's all right. And
yes.
Thank you, everybody.
Okay, I think Ash wants to say something before we close it. And because he has been traveling all day, I think he can have a final comment if he wants to.
Oh, sorry. Thank you. That was a historic hand. Sorry about that. I just got it done. Sorry,
okay. Okay, thank you, Amit, for all this excellent presentation. I know we are running a bit late, but it was on purpose because we had to give time to Andreas to join us. So we were stalling a little bit to get him here on time. And he is between lectures. So this is when you're famous, you are between lectures or in a plane or... So Andreas, the stage is yours to talk us about how to manage the positive converting to negative axilla nowadays after neoadjuvant chemotherapy. We have talked a lot about this during the morning session, but it's never enough, provided that we don't have enough evidence yet. So we hope to get your scenarios, and we hope to agree or disagree with everything.
Lovely. Can
Floor is
you
yours.
hear me and can you see my screen?
Yes, can carry on.
Lovely. Thank you very much for the invitation. A big hi from the Patterson Building at Imperial College in London. I have no conflict of interest related to the topic of the talk. Let's take the discussions one by one. So the first one is a 72-year-old woman, smoker, but otherwise healthy, who presented with a lump on the right lateral chest wall. So she met one of us in the clinic. Clinically, that was a CN2 disease with matted lymph nodes on the lateral chest wall, without any clear palpable lesion in clinical examination and somewhat dense parenchyma. What are the most appropriate next steps in this case? Mammogram, ultrasound biopsy and staging, MRI, ultrasound biopsy, mammogram, MRI biopsy, and staging. Please vote.
So Andreas is starting with a basic question: how we would investigate this lady? I'm really curious to see the results of this poll. Can we see the results? Okay, 63% voted on having mammogram, MRI biopsy and staging, and 1/3 voted only mammogram, ultrasound, biopsy, staging without an MRI. So now it comes again the value of MRI in assessing this patient. Mr. Dasoulis, what do you think?
It's always an argument whether to do the MRI or not. I think this would rely on the mammographic, the initial mammographic findings, and then whether you would think that the breast is dense enough to warrant an MRI, or whether you can clearly see the disease on mammogram, in which case an MRI might not be needed. So
I remember this was a dense breast tissue without any palpable lesions, wasn't that, Andreas?
Yes. So yes, exactly. So the entire point with asking this question was actually I would like to see how many would nap on the clinical impression of somewhat dense breast parenchyma. So we did not do the MRI to begin with, because we resort to the MRI once we understand that we need the MRI, because conventional imaging is not enough. In another note, given the fact that we most often resort to PET staging nowadays, PET can sometimes give us information that will help us understand if we need the MRI. But what we did here was that we did a triple diagnostic.
So you're in line with the Dr. Dasoulis.
Mammogram, ultrasound, biopsy, and the staging, because she presented with clinical signs of locally advanced disease. Okay. So we'll take it to the next step. And
you need to click on the slide before you move on.
Yeah,
otherwise
I did. Yeah. So we had a multifocal, as it was characterized, in an extent of 90 millimeters lesion. The key lesion, the biggest of all, was 18 millimeters, very clear on the mammogram. The ultrasound showed the exact same thing. So we had a footprint of calcifications with some small tumors around the bigger one. The biopsy suggested that we had a near negative HER2 positive tumors, and we also had some more metastases in the infra and supraclavicular fossa. So we had the case of a clearly locally advanced breast cancer, not very many dramatic things from the breast, but still heavy nodal involvement without distant metastases. So she went on and received neoadjuvant chemotherapy with double blockade and anthracyclines taxanes, and post-second cycle, she had almost complete radiologic response. And post-neoadjuvant chemotherapy, she had complete radiologic response in all the modalities. So she had converted from somebody who had locally advanced disease to somebody that had no signs of disease at all. What is the appropriate next step in this context? Would you go for a mastectomy and ALD level 1 to 3, leaving only the supraclavicular previously pathological lymph nodes? Would you do mastectomy and level 1 and 2 ALND? Would you go for response-adapted breast-conserving surgery with ALND 1 and 2, or with a TAD? Let's get the results.
Wait. Give them some time, Andreas. They're not so fast, everybody.
Okay.
We have audience of different levels of experience.
Okay.
Okay, I think that's enough. Yes. Okay.
Yeah.
That's it.
Lovely.
Okay. So most people voted for the last one.
Okay, very well, because that gives me the new hand that I would like to deal, and I will tell you what we did.
Wait. At this point, we need to get one of the panelists to discuss the results. So shall we get Thorsten to discuss it?
Yeah, okay, thank you. So indeed, this is a very tricky question because according to our guidelines, so she had positive supra and infraclavicular nodes. So according to guidelines, she would not be a candidate for target axis resection, to be honest. But myself, I strongly believe that she is a candidate and I would go for solution 4. But this is certainly to be discussed because we do not have sufficient data for N2 and N3. So this is a bit out of evidence. So it's a very tricky case and it really has to be discussed, yes.
Amit?
Yeah, I voted number 4 as well, BCS and TAD, and I completely agree with Thorsten. It is the evidence-free zone. Having said that, if she does have infra and supraclavicular lymph nodes, she is going to get regional radiotherapy. So perhaps targeted dissection with radiotherapy, including undissected axilla, might be the argument without current evidence, I guess.
And Mr. Tasoulis?
Oh, it's okay. Dr. Kuhn and Dr.
you're covered.
have already answered.
So you are on in line of doing a breast conserving surgery plus TAD. This is a voting, I guess. Again, you agree with everybody. Andreas, are you happy with it? With
Yes.
the discussion? Yeah, carry on.
I will just, yeah, I'm happy with the discussion. I will give you the rationale and a little bit of emerging evidence. So recently we got a report from the MD Anderson where they validated the TAD concept for heavier axillary burden. And for the patients that had complete pathologic response, the outcomes were completely similar. So I think that we understand more and more, given studies that, for example, the survival outcomes from the CENTA, it seems like oncological outcomes depend on the response to therapy and not on the extent of surgery. I agree on the fact that the evidence is not formally yet there, but in this particular case, what we did is that we did this. And the reason that we did that is something that I want to discuss in the next slide. So she did have complete pathologic response. She had absence of any other type of disease in the pathological sample, including DCIS or signs of fibrosis and so on and so on. So why did we go for that? Well, the question here is, would more surgery be curative in this setting, given that what we could have offered as a maximal surgical procedure that would have been a mastectomy with an axillary dissection up to the 3rd level would not have gotten rid of the initial disease footprint in the body. So
we vote? Yeah, let's vote. I think it's a good question for everybody to vote. As I said, you can move the poll box with your mouse left or right to see the question. And the question is whether, if we did a mastectomy and axillary left clearance, would have been curative instead of what we did. What do you believe about that? Can we see the results? I think most people agree that it wouldn't have been curative. So I think since we all agree on that, Shall we carry on,
Uh,
Andreas? Yes.
Yes, I would just like to make a comment. So
Yeah, definitely. You can make a
I
comment.
don't have pictures of this lady because she did not consent to photographic material for educational purposes. But I can tell you that she had a shaggy, ptotic breast, a lot of skin, not much breast tissue. So what I did is that I told her, listen, if we are to remove everything we need to remove, basing ourselves on your initial diagnosis, you will probably need a mastectomy. Your possibilities for reconstruction are limited since you have not quit smoking at this point. So what I offered was a Goldilocks mastectomy. So on the wise pattern of the Goldilocks mastectomy, since that was on the lateral breast towards the upper outer quadrant, what I did is that I did my incision on the horizontal part that would then go to the mammary fold if you need to do a Goldilocks on a wise pattern. I did the clipsectomy with the removal of margins. We did the targeted axillary dissection with the understanding that we will try to avoid less disease. The challenge here is that we can always say what we could have done in hindsight, but I think that if we can convey the message to patients that what we are doing is a work in progress and a decision to make an attempt to de-escalation, if this is part of what they are willing to accept, so if they're willing to go back to what would be the default method, I think that this is something that needs to be attempted because biology is more important than the scalpel at this case. We will move now to the next case. We've got a 63-year-old woman, healthy, very, very healthy, lump on her left breast, clinically node negative, a 3 centimeters lump in the upper outer quadrant. And in the mammogram, we see a radiologically T3 tumor, very concordant between mammogram and ultrasound in how it looked and how large it was, and a single node with cortical thickening. To provoke the discussion a little bit more, I will tell you that this is a lady. Our radiologist is very, very meticulous. He usually finds the single node. So the biopsy in the breast and the axilla suggests that we have a luminal B tumor with a Ki-67 of 52%. So the case here is that we've got a CT3N1 breast cancer that is technically borderline amenable to breast conservation that she wishes. We could offer it technically. So do we go for upfront surgery or neoadjuvant chemotherapy?
Okay. It's always a question in these cases, isn't it? Shall we see the results?
Yes, let's see the poll. Lovely. 2/3 would go for a neoadjuvant chemotherapy. I would like some comment from a medical oncologist here. Mr. Angelis.
So this is the classic case for which we argue in the MDMs usually about what to do first, and sometimes
That's why I put it.
Yeah, exactly. So I think it's useful to talk about this. I guess our usual responses, and I think what happened recently that changed a bit of the attitude is the arrival of adjuvant and abemaciclib. So a number of oncologists may say, "Oh, you should go straight ahead in order to be able to access this." But in reality, this is a grade 3 cancer, luminal B. So this is going to need chemotherapy probably anyway. And in this case, I would probably just ask my colleagues and the surgeon say, would that change your surgery? But in essence, I think she should be able to demonstrate some response to it. It's a grade 3 cancer. She's node positive with 1 node, so she could have neoadjuvant chemotherapy if she's fit for it, and which she is. She's only 63, and then proceed to a TAD, for example. So in that case, I would favor for her to have neoadjuvant chemotherapy. And in essence, based on her features, she already is a candidate for adjuvant CDK4/6 inhibitor. So my recommendation would be this. But if there's any reasons why she could not have neoadjuvant chemotherapy, then we would, accept surgery first.
Lovely. So
please, can I make intervention again? Sorry.
Yes.
Because we have people from different countries here, it would be very interesting to know in what countries Oncotype or EndoPredict or MammaPrint or any other test is available on the core specimen.
But definitely not in Greece. So
No, in Greece it's not available, but I'm asking in the UK, are you allowed to send a
Kostas Zachariadakis.
Oh, I mean, it depends what you're asking. We can send Oncotype on the core. We do that when we give neoadjuvant endocrine, for example. We would do Oncotype on the core. But are you asking, can we do Oncotype pre-operatively?
Yes, yes.
This is a different question. I don't think
Yes,
we can.
yes,
No,
yes.
Marius, I don't think we can.
NICE just approved Oncotype for 1 to 3 nodes
Yeah,
positive
okay.
that are postmenopausal. But this started in the last 2 or 3 weeks. So we can now get Oncotype for women who are known to be node positive.
No. Michalis is asking if we can do it pre-operatively
Yeah, we
before
can.
you do it, any type of surgery.
I think we can.
So NICE doesn't actually specifically mention this, but the reality is that TAILOR-X and RxPonder were not designed in this setting. So I think the only time we
Yeah.
usually to request Oncotype on the core is for patients who, as you mentioned, receive
Yeah.
neoadjuvant endocrine therapy.
That's my understanding. So pre-operatively not. And we were late to accept doing Oncotype DX for node positive patients. That's what Mario said. NICE actually recognized that a few weeks ago. Up until now, only with funding from their own hospital would you be able to do that. So we're not doing Oncotype DX for node positive patients. So no.
So in Sweden, we are using the PAM50 for the postmenopausal, which has been validated on bioptic material. So that if that were a concern, so if we had a tumor biology at the gray zone where we would have to make decisions based on that, that would have been an option, obviously.
Okay.
Now,
Yeah.
it was a very striking example of an aggressive luminal B that had a T3 tumor. So as Mr. Angelis highlighted, this is a patient that from the get-go, you would know that she qualified for a CDK4/6 inhibitor following her treatment. So 2/3 went for that. And let's continue to discuss this. So this, I will leave it to the medical oncologists. Do we do dose dense or not in this one? I just put this question because the 10-year Panther data were
Oh, it's not for poll. This is not for voting. So this is just for discussion. Ilias, what do you think?
Yeah, I think dose-dense chemotherapy is the preferred option here. I think also it's mentioned in the NCCN guidelines where for younger patients, dose-dense chemotherapy has proven benefit compared to a 3-week regimen. So I think I would opt for dose-dense chemo.
Okay, are you happy, Andreas, to move on?
Sure, yeah.
Or do you want
Yeah, I
anything
just
else?
want to-
Any input? Any further input? No, I think we're fine with it. Shall we carry on?
Yes, we can move on. Lovely. So after the second cycle, we still have half of the tumor that is visible. The ultrasound in the axilla still has somewhat cortical thickening, looks better, but not really normal. And afterwards, we do have density and irregularity, which is assessed as a 75 patch type response. So the footprint has not reduced significantly. But the axillary ultrasound is now normal. So our radiologists inform us that they would classify that as a YCT2N0. So the question here is, what is the most appropriate next step? Mastectomy and axillary clearance, footprint-based breast conservation and axillary clearance, response-adapted breast conservation with axillary clearance, or response-adapted breast conservation with targeted axillary dissection. Please vote.
So it's a combination of decisions, what to do with the
Yes.
initial tumor and what to do with the axilla. Remind you that the axilla has not been
The
or
axilla
has
had-
been.
Yeah, the axilla was normalized following the completion of chemotherapy, not on the second cycle, but it was for
on the end.
The tumor is somewhat smaller, but it looks like a patch type response radiologically.
Let's see the results. Okay.
Okay. So most people would be keen to de-escalate. Torsten, and then
I think while the time passes, more people are up to doing less surgery. By the end of the webinar, nobody will be operating.
No, I think we will still be operating, and there is a good reason for that for most of the patients. But I mean, Torsten, your thoughts? I know that you like patch type response.
Now, I think we all agree that minimal invasive stages, target axis resection is the preferred technique today, although long-term data with the sufficient statistics still lacking. I think Oksana will provide these data, but I think we all agree that target axis resection is safe compared to axis resection.
Okay. With regards to tumor, I did the response-adapted surgery. I can already now disclose that, but would anybody have concerns with regards to that? I remind you the technical aspect of that the patient was from the beginning amenable to breast conservation, somewhat more generous, but it would go. Marius, what do you think?
No, I would go for response adapted breast conserving surgery.
Okay. Kostas, any discussion from your side?
No, I think so there was a patchy response, so it was not a concentric response, correct?
Yes.
Yeah.
Yes. It was.
So
it
like
was
a honeycomb kind of response.
Yes.
So I would, I would remove that. If you mean by response adaptive breast conservation, removing that whole area, yeah.
Yeah. Yeah.
Yeah.
Okay.
I
Very
think
well.
Amit wants to say something.
Amit, yeah.
Yeah, sure. Basically, I think probably I understood patch as what's left behind.
Yes.
So, but if it's footprint like Swiss cheese pattern, then certainly, as Andresi said, she is kind of conservable. She's not like not conservable upfront with or without chemo. So yes, I would remove the footprint and targeted dissection. I think we all agree anyway. Thank you.
Okay. Lovely. So what did we do here? We did footprint-based BCS, given that the change was not very important, and this is why I did not give that as an alternative. So we had an RCP2 in the breast and negative nodes in the axilla. So the questions for that, like my thoughts is, does non-clinical or radiological complete response in the breast mean the same for the axilla? We have traditionally seen in previous studies and meta-analysis that surgeons made the decision to do more extensive surgery in the breast if the patient had more axillary involvement from the very beginning. But the point here is that she had a low volume axillary disease from the start. So this would be somebody who could be included in the TAXIS trial or do an upfront TAD. In this particular point, the biology was very clear and the stage was very clear for the beginning. So trying to look for more nodes would not change any recommendations for the adjuvant treatments that this patient had. This is how we thought, and this is what we did. I would like to ask the panel, both oncologists and surgeons, if they would think differently in a similar scenario. And I would leave it as a free floor.
Rangelis.
So from our point of view, I think it wouldn't change what we would do in the adjuvant setting. We are able to access abemaciclib in this setting based on the original features of the presentation, regardless of the response to treatment. So even if they did have a complete response in the axilla, they would still access endocrine therapy combined with the CDK4/6 inhibitor. But obviously, the patient will have less comorbidities if they had less surgery.
Another thing that we have been discussing with Torsten very often, and I think that we think alike, is that we believe that for patients that need chemo because of their subtype, bigger surgery at the get-go will result in delay of systemic therapy, and bigger surgery has the tendency to correlate with higher complications. So delays in adjuvant treatment, we know that they are deleterious to oncological outcomes. So there is a good rationale from a surgeon's perspective to ask for pre-treatment, because whatever happens afterwards does not yield the same type of consequence for the patient, because they have gotten the systemic treatment. Torsten, am I correct in saying that?
Yeah, I think the issue that we currently discuss about the luminal tumors, but I don't have the results yet, but we will analyze this in a very short time, is the response rate in the lymph nodes. It is our impression that in this case, you have a pathologic complete response of the lymph node, but the rate, and we will shortly analyze data from Axana, and it is at least our experience that in luminal tumors, the complete response rate in the axilla is quite low. And for this reason,
I agree completely. This is in line with previous results.
And the next step that we discussed was with the MONARCH E study, the abemaciclib was indicated for patients with 4 or more lymph nodes. So
grade 2 tumors.
So we disguise by the neoadjuvant approach, but now again with the NATALEE study, we have node positive patients who are candidates for CDK4/6 inhibitors. So I think it's still an open issue. So we don't know if really. So in Germany we had the rule for many years: whenever the patient had an indication for neoadjuvant chemotherapy, do it upfront. So we do neoadjuvant chemotherapy for many, many years. But now this is rediscussed with the luminal tumors and the response in the axilla. I think it's still open.
Good. In this particular patient, I think that the inclusion criteria from the MONARCH were present and shining from the beginning. So we did not hesitate with regards to that. I see that Mr. Angelis has his microphone up.
Yeah, because I just want to clarify that the criteria that we use, at least in the UK, is for patients with 4 or more nodes, but also for 1 to 3 nodes with either a grade 3 cancer or a cancer that's more than 50 millimeters inside.
Yeah, okay, I agree. In this case, it was clear because I think the tumor was 5 centimeters, no?
Yeah, so in the beginning, it was 52 millimeters and grade 3. So from the beginning, she filled the criteria.
Yeah,
so she was
irrespective of the lymph nodes.
Yeah,
agreed.
So
I agree.
Let's move to the next one because I pushed everything by mistake. So it's a 51-year-old woman, healthy, a screening recall, and there is a small lump and a single node. And we now have a triple negative breast cancer, KI 67-79%, axillary metastasis. So it is a CT-N1. We move further, and PET shows no distant metastasis, single tumor, single node, so no discordance. We request a genetic panel, and she undergoes treatment per keynote 522. Halfway there, you have a complete radiologic response. And in the end, you have a complete radiologic response as you had from the very, very beginning. And we find that she has got a germline ATM mutation. So this was a fun surprise. So the question now is, what is the most appropriate next step? Response-adapted breast conserving surgery and TAD, bilateral mastectomy and TAD on the right, response-adapted BCS and ALND, bilateral mastectomy and ALND on the right side. Please vote.
Just remind everybody, is a T1 NE1 tumor who had a complete response. It was 15 millimeters in the beginning, from the beginning, sorry. So just remind you a couple of things.
Single node and ATM mutation.
So the question here is whether we believe that ATM mutation is significant for the decision making, isn't it? This is the main question, I guess. Okay, let's see the results. Let's see the results. Let's see who believes that ATM. Okay, we split it. That's a good thing. This is what we need, 50% and 50%, almost 50%. So
I would say that we have a 56 versus 44, so it's a close one. That's very nice. So I would like to leave the floor open for comments on the need for mastectomy and what we are trying to achieve by doing mastectomy in cancer patients that find that are found with a genetic mutation, and if we feel that all genetic mutations are alike.
Andreas, let me rephrase it a little bit.
Yeah.
Can somebody comment on the breast conservation plus TAT? That means that we don't believe that ATM would change our surgical
Yes.
plan. Thorsten, would you mind taking this role?
Yeah, I agree entirely. If there's no genetic test, so we will have no, if there's no real genetic risk, and I think what's ATM is not
Yes.
real
Yes.
genetic risk, so there's no advantage.
Marios, what do you think?
Same. I will not say anything about ATM for now because I think this will be discussed. But in terms of overall survival for somebody who already has a cancer and they are found to have a genetic mutation, most of the times prognosis is already determined by the index cancer. So again, there is some data to suggest that performing mastectomy and even contralateral mastectomy may or may not have, some small benefit, but data is not robust, not conclusive. So in the absence of robust data, I would not offer bilateral mastectomy unless somebody was very keen on that.
It's mostly for BRCA1 and 2, isn't it? It's not for ATMs. Whatever we have is for BRCA1 and 2, which is the majority. Amit, you want to say something? I think I can see your hand raised here.
Yeah. Basically, just to echo the thoughts already mentioned, ATM mutation is not as high risk as BRCA1 and 2. And of course, she's already had node-positive triple-negative cancer. Now, in terms of surgery, I would like to ask the oncologist whether they would be happy to give radiotherapy, because there are some concerns often expressed with ATM gene mutation, and that will guide me to help the patient decide which surgery to have. It's a question in my comment.
Sorry, there is no reason for bilateral mastectomy, and
No. The question is whether, because of the ATM, you would hesitate to give radiotherapy.
No, that has nothing to do. That was a belief in the past. We care about P53, but not about ATM. It's not a problem to irradiate a patient with ATM. And since it is intermediately penetrative, it's not important to have mastectomy.
Okay, so there's no problem with this mutation. You would only have concerns about giving radiotherapy with mutation. Can you repeat that for everybody to listen?
So the discussion here is the ATM, and there had been concerns about the ATM with regards to that those patients are more prone to further carcinogenesis, but that has been looked at a little bit more in detail, and it is the truncated mutation, which is only the 2% that has a somewhat higher risk, but that has not been found to be statistically significant. As Mr. Margoudakis highlighted, the TP53 mutation is a different story, and there we are very, very concerned, and we avoid any type of radiotherapy. So, taking it further, this is what we did, and this is what we found. So, the complete radiologic response was not a complete pathologic response. We had a YPT N1, Ki67 9%, so the treatment pushed the brake on the tumor. We had 6 lymph nodes, and the clipped one, the initially metastatic, still had what we would call a micrometastasis per conventional criteria. So, what is the most appropriate next step? ALND, radiotherapy to an undissected part of the axilla, or nothing? Radiotherapy in the breast goes without saying. Please vote.
So we take for granted the radiotherapy to the breast, and then we carry on with the second part, what we do for the axilla here, okay? Just to clarify the question.
Yes.
I mean, that question would have been clear 5 years ago, wasn't it?
Yes.
And it's going to be clear in 5 years from now, but now we're in between. Okay, shall we see the results and see how it goes? Okay, so
that's a good one.
that's okay. That's a good one. Yes.
So, that's a good one.
Pick one.
So, I would like to leave the floor open primarily to the oncologists with that. Any insights?
Elias.
Well, I think breast surgeon is more appropriate to answer this question, not medical oncologist. But I think, as Sophocles said 5 years ago, we definitely choose for option one, L&D.
Yes.
But now we may consider to de-escalate this type of surgery and may offer radiotherapy. And if I'm not mistaken, this is the current status. Okay.
Mhm.
We're waiting for the Alliance trial, obviously,
Yeah,
to get the results of that one. So hopefully we're gonna get that about.
I would like a surgeon that would go for clearance and the surgeon that would not go for clearance.
To
Who
be
would go
honest, I
for
would,
clearance?
although I believe I'm wrong, I would have gone for clearance. But yeah, maybe a low level clearance. I wouldn't go up. But
Okay.
yeah, but that's only because there's no current evidence that I can get away with the recurrence, which is highly unlikely to happen. But if it happens, I mean, you cannot defend yourself for doing that unless if you consent the patient for the lack of evidence and the emerging evidence. I believe that in a few years it's going to be malpractice to do lymph node dissection in these cases. Yeah, but
Also, would you say something?
Maybe I come up with some data, because the first question is, what is the diagnostic role of any axillary surgery? So patients has non-PCR, which has already been proven by residual disease in the breast and the micrometastasis. So for systemic treatment, it is clear she may have capecitabine, for example. She is no BRCA carrier, so no PARP inhibitor. For regional treatment, it's the question, what is the probability of having non-target, non-central lymph node metastasis? And we have the paper from Tracy Mew from, I think, 2018, showing that patients with micrometastasis in the target lymph node or the central lymph node have quite a high probability of having additional lymph nodes, which is about, I think, 40-something%. And now the question is, do we believe in axillary section to achieve regional control in the axilla, or do we believe in radiotherapy? And in this context, we are certainly still awaiting the Alliance trial. So most guidelines, for this reason, most guidelines still recommend axial lymph node dissection. But to be honest, we all believe that radiotherapy will be equivalent to axial lymph node dissection. And I can tell you that in this scenario, we just had an interim analysis of Axana. About 60% of surgeons worldwide do not go for further axial lymph node dissection, and 40% go for axial lymph node dissection. So these are data from the Axana study. Personally, I think I would not go for any further axillary surgery.
Okay, very nice. So this
that was a very good question, Andreas. A very good question. This one.
Just a word of caution, though, I guess for this population of patients, I think none of the patients in Alliance were really receiving a Keynote 522 regimen, and I think the question is whether we're dealing with a more aggressive disease here that we are not really have much experience with regards to response to this type of chemoimmunotherapy, because we have experienced patients that demonstrate a resistance to this treatment and then have a widely rampant aggressive disease in the adjuvant or metastatic setting thereafter, soon after. So I think we have to be a bit cautious about this because they may not be necessarily in this study.
So would you be happier with an axillary lymph node dissection in this patient?
Well, clearly you might be over-treating the patient here. So I think we just need more data and more experience with this regimen in this subtype of breast cancer. But if it was a younger patient and they didn't have a complete response, I would be worried.
Very nice.
Thank you very much. Yeah.
Thank you for that. So
Andreas, thank you very much for all these important cases.
So just to finish, we did not do nothing. Why did not we do anything? She declined that. I informed her. She told me that she was negative. I informed her after hearing that she was negative that L&D is the standard of care since we don't have the results. On the other hand, something reassuring was that there was low volume disease from the start on the PET. And yes, with the ATM, we know from the carrier study that this mutation does not confer increased risk for future contralateral events or a high absolute risk. So the difference in the absolute risk for a secondary new cancer in the same breast is 1.7% in these cases, so nothing more is needed. So having said that, I would like to thank you for your participation and your engagement in these cases. Thanks a lot.
Thank you, Andreas. Thanks a lot for that. So we're moving to the last part, where we have 4 cases prepared, and we have half an hour until the end of the webinar. I think Michalis, we should carry on and see how it goes and finish it 10 minutes before 4, up to whichever case we reach. What do you think?
Should we take 1 minute break?
Yes, we can do that and take a breath. Yes, we can do that.
1.5 minute break?
Yes, to get some water. Yes, I agree with you. Let's take 1.5 minute break, and then we carry on with 4 very short cases, I promise, and completely different than the ones we have discussed up to now.
All right. Sophocles, would you like to... Giuseppe is with us.
Yes, hello, Giuseppe. So since you haven't been with us for the rest of the meeting, for this
I'm
this
very
part
sorry.
is, you will have lots of time to speak in this last part, I guess.
Okay, thank you.
Welcome to you. So shall we carry on? I mean, we will be quite quick on that one, and we'll try to finish just in 15 minutes or 16 minutes. I don't know how many cases we're going to manage to do, but let's
think-
start and see how it goes. Okay?
We want to start with the first one, and then I will take over.
Yeah, just let me
With the
share my
second
screen.
one.
Just... Okay. Miscellaneous critical cases. Okay, so I'll share my screen now. I hope you can all see my slides. Yep, are we happy?
Yeah, we can, yes.
So we carry on with this first case. We have a 67-year-old patient. She's postmenopausal, of course, with a C cup size. And she came with a screening lesion that was 2 centimeters in the right upper quadrant of the breast, with 1 lymph node, a suspicious lymph node on the axilla. And during the staging, we found 1 single lesion on the lung. So we had a T1, NE1, M1. From the family history, it was unremarkable, and she was actually good performance style. She was well, healthy and well. So this lesion was biopsied and was a non-specific type, grade 2, ER 100%, PGR 20%, Ki67 was 60%. We do that routinely in our clinic, and HER2 was score 1. So there was a big discussion about the single lesion in the breast. So we tried to investigate that, and we did a biopsy on that lesion. Came back as a ER less than 5%, PGR 0, Ki67 40%, HER2 score 1. So we're quite puzzled whether that was a primary breast cancer or was a metastatic from the breast. After a lot of investigation, it's not the point here to discuss what we did, but we did a lot of things, and we finally decided that this was a metastasis from the breast, despite the different immunohistochemistry profile. So this patient underwent primarily chemotherapy and pembrolizumab, and she had an excellent response of the lung lesion, almost completely disappeared on imaging, and there were no other secondary lesions after the end of the chemotherapy. In terms of the breast, there was a smaller response, but in the axilla, there were no abnormal lymph nodes after the, let's say, primary chemotherapy. She had a genetic test, was negative. So after that, and after discussion, the question is what to do after that. It was a T1, NE1, M1 with one single lung metastasis. She took this treatment. The lung metastasis disappeared. The one in the breast got smaller. The axilla disappeared. And the question is what to do now. Do no surgery since it's a stage 4 disease. Only systematic treatment, radiotherapy for the metastasis. Do metastasectomy, remove the lesion of the lung. Do a wide local excision plus minus sentinel lymph node biopsy of the breast lesion. Do a modified radical mastectomy, or a combination of the 2 and 3, 2 and 4, or any other option.
Can I
Shall
ask
we
you
see the
something?
results? Yes.
What kind of chemo did you give her? Did you treat her in a curative intent or in a palliative chemotherapy with
It was a
pembrolizumab?
curative intent.
So, Keynote 522?
I think so, yes.
Okay, let's vote. I would like to ask how long after the completion of systemic treatment are we having this discussion here? So has she been stable for 6 months, for 1 year, or for 6 days?
Is for the duration of the chemotherapy. By the end of the chemotherapy, it was these results. So she was restaged and was found to have these results. So can we see the results?
Oh. Why sent a note?
Michalis, would you like to give?
Yes, I'm trying to count who is winning here. Choice 5, which is metastasectomy, plus surgical treatment of the primary lesion. Okay. I would like to take the surgeon's opinion.
Giuseppe, I think Giuseppe is allowed to take the first comment.
Is allowed. Giuseppe?
Thank you very much. Yes, sorry for the delay. So this is a very complex setting, very complex situation. So it's kind of, you treated this patient with a neoadjuvant treatment, although she had metastatic disease. So it's not exactly what I would have done. But anyway, problem is that now we are going back to a situation in which the primary disappeared, but at the origin, she was still metastatic. So from my point of view, probably no surgery. I would have treated her as a metastatic patient and just observation. Obviously, I would wait for a while, not immediately, not at the end of the primary chemotherapy. But anyway, I would have treated her as a metastatic patient at the onset. So no surgery.
Ash, are you with us?
Hello, sorry, is that me?
Ash, or yes?
Yes, sorry.
Yes.
What was the question? I missed it. I'm sorry. I was just on a call.
So the question is whether we had this patient with a T1, N1, M1 had a chemotherapy.
Oh, no, I know
pembrolizumab.
that. So sorry. Okay, so how
What
long
would you-
how long has the response been maintained in the lung for before we considered surgery? So if
Just
we are
after
considering surgery,
the end of
I
the
think
chemotherapy.
at the end of chemotherapy, you've got a complete pathological response in the lung, but you've got residual tumor in the breast and nothing in the axilla.
Complete
My
imaging
answer would-
response. We're in the stage that we have complete imaging response. We haven't done anything surgical yet. So,
So
whereas,
2 and 3 would be my response.
so you have done a metastasectomy plus white local excision and central lymph node biopsy of the breast.
Yes, or you could do it, even stage it and do it in a different way, where you could do the wide local excision and sentinel node biopsy of the breast, because what I heard was you started treating this patient with a radical intent.
Yes.
So the radical intent would be then to complete the breast surgery and then do a metastasectomy, and then observe this patient with continued systemic treatment.
Dr. Angelis, what do you think?
So I guess, so this is a triple negative patient, right? Yes.
No. It was a luminal on the breast with a different type of metastasis in the lung. It was ER low, less than 5%, considered triple negative, PGR negative, HER2 negative. On the other hand, it was a bit of an ER positive, PGR low on the breast. So it was a luminal on the breast and almost a triple negative on the lung.
Yeah, I see. Okay. It's just because we only usually access pembrolizumab in these patients if they're proven to be triple negative and PD-L1 positive. In reality, this patient is by virtue of the presence of a lung lesion metastatic. So we don't have a lot of evidence for this subpopulation of triple negative with regards to oligometastatic kind of management with local regional treatment, but would give her the benefit of doubt and offer her surgery after the response to treatment, to systemic therapy. But it won't take away the fact that you will continue treating her as a metastatic patient and scan her every 3 months. But given the fact that we don't have very solid data on this setting, you probably would try and offer her surgery to the lung lesion and the breast lesion. The problem with this, though, is if you're classing her as a metastatic patient and we keep following up, is would you then carry on and give her radical treatment with radiotherapy and etc.? So I think that's the question for patients here, which we tend to do.
Okay, let's see what happened then. So this patient had this lung resection, and I have a bar in front of me, so I cannot really see how it says. It was a residual fossa was 2.5 millimeters, but there were 7 of those little tiny lesions, and all of them had the same profile as the breast, which was ER positive, HER2 negative, completely different than the one we had from the beginning. Obviously, whatever was triple negative disappeared from the chemotherapy. In terms of the breast, she had a white local excision plus a central lymph node biopsy. It was 1 out of 2, lymph nodes positive, and was a residual 18 millimeter non-specific type, the same as the beginning, ER 100, PGR low, 0, HER2 negative, Ki67, 15%. So eventually what we had, it was the residual metastasis, which was similar to the one of the breast, while the triple negative part disappeared completely. So the question here is how to continue with this metastatic breast cancer, using pembrolizumab plus capecitabine, using CD4K6 inhibitors plus AI, like a luminal cancer, or a combination of both. Hopefully this would be tricky. And can we get the poll box to vote?
Can I ask if you did the receptors on the lymph nodes?
Yes, it was the same. Exactly the same. And we did it from the beginning. We also did it on the beginning. Okay, can we see the results, please?
Oops.
Okay, so I'm not going to ask Elias. I'm going to ask Dr. Angelis to tell me his opinion now.
The reality with this patient is that, it's a very complex case, but you would probably just opt to treat the HR positive, HER2 negative disease and offer this patient CDK4/6 inhibitor and AI. I don't think there's any evidence that using here pembrolizumab and capecitabine, there's no actual evidence for ER positive and HER2 negative population to do this. And if there was an element of triple negative disease that responded to the previous treatment, then that's a great news. But I think it would be not also reasonable to start this patient on cytotoxic chemotherapy. So I think my recommendation for this would be to probably treat the HR positive, HER2 negative as usual with a ribociclib and hormone therapy, and then continue to monitor the patient.
Thank you very much. This is what it was actually decided to be treated such as a metastatic ER positive HER2 negative cancer. And the next question is what we do after that. Of course, the answer is not white or black, but do we do axillary lymph node dissection, radiotherapy to the breast and axilla and suprainfraclavicular area, no further treatment apart from what we already said, or radiotherapy to the breast only? Still no guidelines for that. But let's see, what do you think? Shall we vote? Okay, can we see the results, please? Okay,
Wow.
Mr. Maragoudakis.
Well, we have treated this patient aggressively, so we have to take it up to the end aggressively. And since we have one sentinel lymph node involved, so there is a possibility of recurrence, I voted for radiation to the breast and to the remaining lymph nodes that were not excised, with the hope that the disease will come back after a long, long time. Otherwise, we don't have any reason to be so aggressive with a patient which is de novo metastatic. But since it was a sole metastasis, I think that everything has been done the right way.
I think Ahmed wants to add something, and Ahmed has risen his hand.
Yeah, I mean, basically a slide earlier I wanted, because I would probably would have wanted to repeat the receptors, because there's something about it doesn't fit. It's grade 2, but Ki67 of 60%, ER positive whilst ER negative tumor. Are we assuming it's gone, or was it never there? And the second point, which I probably want to ask the radiation oncologist, would they consider SABR stereotactic ablative radiotherapy in this setting? Thank you.
Very good point. Thorsten, you wanted to say something too?
Well, just a comment. I'm muted? No, I'm not. No, just one comment. I think the decision was taken at the beginning to decide this is oligometastatic, will we go for curative or will we go for palliative treatment? Once we decide for curative treatment, and you started even with a keynote 522, very aggressive. So you wanted to be curative. So all other steps for local region treatment have to follow the current guidelines. Not more, not less.
Will the subtype of the tumor influence your decision for curative intent or for, metastatic disease?
Ooh. This is really a difficult question. So if she was triple negative, I think the former comment was really nice. You have to reevaluate tumor biology. Is this really to have the ER negative metastasis and a completely different tumor? So I definitely would go to a second opinion for the pathologist and reevaluate the tumor biology.
From what I remember,
it was done. It was reviewed a couple of times. Everything was reviewed a couple of times. Yeah.
Okay.
Giuseppe, I think he has raised his hand.
Yes. I do agree with Thorsten. The decision was made at the beginning, but what I would like to highlight is that still now this is metastatic disease, because in the lung resection there is a residual foci. So overall, it's a very complex situation to manage now. We have conflicting information regarding this disease, but for the moment, for sure, we know that it is still metastatic disease. So
yeah,
I don't see the point for very aggressive local treatment just for maybe just for local control, but this is metastatic disease, resistant metastatic disease, and here we are.
So you would go only for radiotherapy to the breast, I guess,
Or nothing.
or nothing. Nothing. No further treatment. Okay. Okay. Anybody else wants to add something on this difficult, complex?
That's just one comment.
Sorry, I was wrong. I mean, not local regional further treatment. Okay, not nothing at all, obviously, because it's metastatic disease.
Yeah, I understood that. Yes,
In this case, just one comment, because it's a very, very interesting discussion. But the highest morbidity is from chemotherapy, from Keynote 522, and compared to the morbidity from this really aggressive chemotherapy regimen, I think local region treatment is of minor morbidity. So I think once you say A, you have to go for A and not change to B, if you start with such an aggressive treatment.
That's a good comment. That's a good comment indeed.
Good point.
Okay, anybody else wants to say something? I know this is it's all out of the guidelines cases, so there's no correct or wrong answer. It will show in the near future or late future whether that was a correct or wrong decision on this patient.
I see Papadakis and Yannis Natiopoulos have raised their hands.
Yes.
Yannis, you want to add something?
I agree with Dr. Papadakis. It's a metastatic disease. 7-19 foci, lung foci. We have to prevent the next metastasis, not to try to control the local disease. It's not a local disease. It's a systemic disease. It needs systemic treatment, the whole body treatment, not local radiotherapy, surgery, etc.
Yeah, well, it's all given. Okay, so we can talk for ages for this case. I guess we will have to rediscuss this case in about 3 years from now and then in the future. So we don't have time for all 4 cases, but I will give the stage on Michalis now to present this last case, and then we'll close it because we don't want to delay you from whatever you have to do after 4 o'clock. So Michalis, this is the last case. I think you should carry on and take over.
Let me just...
I'm just going to press the slides and you can tell me to carry on, okay?
Okay, fine then. So you hold right. So this is the last case for today. It is about a 46-year-old patient, premenopausal, who presented with a T2 clinically T2 lesion in the breast, and the ultrasound scan revealed the lesion 2.7 centimeters with some satellite lesions around it. Clinically, the axilla was negative and M was 0. We did have an MRI scan. She had dense breast, premenopausal, etc., etc. And we did find a multifocal lesion measuring in total 4.9 centimeters in maximum diameter. The total area of which hosted the tumor foci, and the diameter, the maximum diameter of the biggest lesion within this foci, within this area, was 2.7 centimeters. We did have a core biopsy, and it revealed rather luminal A breast cancer, ER 99%, PR 87%, HER2 negative, KX are very low. But the ultrasound scan of the axilla showed one node with a slightly swollen cortex, which led to an FNA, which was positive. She had 0 family history and no remarkable history. So the first question would be, what's next? She is a premenopausal woman with a node-positive breast cancer, but a luminal A breast cancer. So the questions are neoadjuvant chemotherapy, okay, and she's going probably to have chemotherapy anyway, although not everybody agrees with that. or should we do neoadjuvant chemotherapy in an attempt to salvage the axilla, or upfront surgery, oncoplastic surgery with wide local excision and sentinel node biopsy, and if it is less than 2 positive nodes, make use of the Amaro Z11, etc., Xenomac trials, etc., and avoid clearing the axilla, or upfront surgery with axillary clearance, or mastectomy with some type of axillary procedure. So let's put up the poll box, please.
So previously, it was mentioned that if a patient's going to have anyway chemotherapy, ideally, or most of the times, we would give that upfront before the surgery. Do we agree with that in this case, in this lady, or do we think that an upfront surgery is a better option? Let's see the poll results. Okay, most people believe that upfront surgery would be better than giving neoadjuvant chemotherapy, despite the fact that most likely this lady will probably need chemotherapy in the future.
You see, biology is the king, I think. So Amit, you raised your hand.
Yeah, I raised my hand before the poll results, thankfully. I'll be probably 3.5, really. Certainly, I would go for upfront surgery. She's premenopausal, but the biology, as you said, is the king. It's great too. ER, 99, 87. If you do oncotype, etc., she will be low risk. Ki-67 is 7%. So she's one of them who should have upfront surgery, and perhaps a bit more than sentinel node, because Amaris or Z11, they're all post sentinel node setting, and maybe a sampling kind of surgery. It's certainly not beyond level 1 to see how many nodes are there, and her benefit might be more from AI and CDK4/6 than chemotherapy.
I think Kirsten has his hand raised.
Yeah, I think this is another very interesting question. So we would probably go for upfront surgery as well. And then when we have a mismatch between the tumor biology and tumor stage, and we probably in a luminal A tumor, we would not rather expect an axillary involvement, then we always try to confirm the luminal A tumor by looking at tumor heterogeneity. That you may have luminal A in one part of the tumor, but a higher proliferation in other parts of the tumor. And then we also do the Ki-67 on the lymph node again, in order to have a very clear statement on the entire tumor, to then decide whether to give chemotherapy or not. Because even if it's the luminal A tumor and we have a low nodal burden, we would not necessarily go for chemotherapy, but we would try to have a very good image of all parts of the tumor.
So upfront surgery for you too, isn't it?
Yes.
Okay, Giuseppe, I think you have raised your hand. No? Giuseppe?
No, yes, sorry. And this is upfront surgery even for me. I would like to have more information on the lymph node as well. So I will do a core biopsy on the lymph nodes. And also, I might have missed how many lymph nodes involved in the ultrasound. Is it only one?
That was none initially, but when we did an ultrasound in the surgical unit,
I mean,
we
on
found one
ultrasound.
it's just one with a slightly thickened
Just
cords.
one.
I mean, it's in the border of not doing anything on that, but we did an
Yes.
FNA and it was positive. So yeah, let's say that.
So yes,
Borderline.
I will go
positive
for
axilla.
3. I will go for 3. And obviously, I would like to see the patient before. Obviously, it depends on the tumor to breast ratio, because the lesion is quite large. It's 4.9 centimeters, 2.7 plus 1 centimeter of satellite lesion. So I would like to see the patients, the BMI, the nipple to sternal notch distance, and all the other morphological characteristics of the patient, and then wide local excision if it's feasible.
Okay, there you are.
Okay.
Now you can see them all.
Should we listen to a Medong's opinion? Ilias?
Yes, so I think we have a typical lobular cancer here, luminal A, very high ER/PR expression and low Ki67.
Elias,
So
sorry,
I-
it's not a lobular, it's a NST, it's non-specific type, it's not lobular.
It's not lobular.
Luminal,
Okay.
luminal A.
Okay, I'm sorry. So I think, with it's a luminal A tumor. Anyway, it's a luminal A tumor. I think there's no benefit from neoadjuvant chemo, and I think option 3 is the best for her.
Okay.
But just as an add-on comment to Elias, I think, you know, it does behave a little bit like a lobular. So I would probably repeat the histology and look at the immunos in the node as well to just make sure. And we tend to do core rather than FNAs for that reason, because it could be potentially that it has a degree of mixed histology. So we would like to exclude that. But ultimately, I think we'll have to be also cautious about oncotype here, because if this is a premenopausal patient that's node positive,
That's a good point.
know from our responder that there would be benefit regardless. So I think we should be cautious about using this in this population before surgery as well.
Would you rather use another molecular signature other than the oncotype, which is
Mike,
by
Michalis,
definition
Michalis, just
positive?
hold your horses for the next one.
Okay.
Yep.
There it is. Yeah.
So,
okay then. So what we did, also Sophocles did with this patient is they did a complex breast conservation, oncoplastic mammoplasty basically, which revealed 3.9 centimeter NST grade 2 with extensive intraductal component around the tumor, measuring in total to an area of 5.2 centimeters with LVI, good margins, and ER positive, PR positive, HER2, I guess this is negative in case 67 is 10%, and 1 out of 4 lymph nodes were positive. So the question here is whether you would use another signature other than an oncotype, because oncotype by definition, due to the RxPonder trial, consider this patient suitable for chemotherapy, or this patient, due to her age, etc., would need chemotherapy anyway, and no signature is necessary. Please vote.
I think that covers the comments of Dr. Argelis about the use of genetic signatures in this population. So we'll see the poll, obviously, and then discuss it as probably one of the 2 last discussions. Okay, shall we see the poll? Shall we see the results, please? Okay, split it.
That's interesting. So half of us believe that because of her age, probably, and the node positivity, she will need chemotherapy anyway. And half of us believe that let's give it another try to see if we can avoid it. Right. Is Giorgos Metaxas with us?
And you ask the oncologist first to give us
Because he made a comment on the chat box, that's why.
Okay.
But if Giorgos is not with us, let me ask Ilias. Ilias Koteas, what do you believe?
Well,
I'm here actually.
so
Giorgos, give me a second, I'll ask you next.
Yeah.
okay, so I think that she's a premenopausal with NEO1 disease. Am I right?
Yes.
So I think we are compelled to give chemotherapy here. Even how we deep inside us, we think that we may overtreat this patient. I think there is no need for further evaluation with another tool here. Okay.
So by definition, she needs chemo and no need for any other tests.
Dr. Argelis?
So I think this case is talking about basically comparing Prosigna to oncotype, and there's some recent data that they did a direct comparison between the two, and found that patients that may have a kind of less predictive score for benefit from adjuvant chemotherapy may have a higher risk of recurrence within 10 years. In some centers in the UK, very small centers, probably maybe just the Marsden, I suspect, they're doing both in some patients, Oncotype and Prosigna, which you could consider not sustainable elsewhere. But I think I agree, Tento, what we have on this occasion. I would probably be offering this patient chemotherapy just based on the RX ponder. But I think generally it's something that's under discussion of whether for the premenopausal population in general, we should be cautious about just using Oncotype, because the data for that is a little bit hazy, although the definition of what is premenopausal is what makes that a bit more complex in the studies. But I think at the moment, the way we are, I think it's inevitable not to offer this patient chemotherapy. I guess the question would be, what type of chemotherapy? Could you spare the anthracycline? Could you offer them a better regime that may not give them as many toxicities in the future? That's the actual question. We don't know. And there are studies that are looking at basically these patients, whether they would benefit just from ovarian suppression rather than chemotherapy, but we're still waiting for the results of these.
Okay.
Any other insight on this? Yorgos, Metaxas?
No, I actually saw this case as let's say it could be a case of a delayed diagnosis of a low-risk tumor. So I think by giving chemotherapy any way, we are just denying the chance that this is a really low-risk tumor. But I think there should be a way that we could find out, and there should be a way that we could define the exact benefit of chemotherapy when we discuss this with the patient. I think if we wait a year more, maybe she would have another lymph node positive, or if she came the previous year, she might not have a positive lymph node.
Most likely, yeah. So this is what she had. And just for the records, the patient refused to have chemotherapy. She underwent an EndoPredict, came back as a low score, and she decided not to get chemotherapy. She get an OFS plus a hormone treatment. And I think that was it. I don't think she got anything else. She refused to take any more therapy than that. She refused that from the beginning, I guess. So it's a patient's option, I guess. Giuseppe, you want to say something?
Yeah, I think she also refused a technique on the other side, the operation.
No,
not
she's gonna have that. No,
control
she said okay. She's gonna have that.
delayed.
Yeah, delayed. Yes.
I guess what's interesting to mention in these patients is we don't know whether, because she could possibly qualify for abemaciclib. She's got 5 centimeters, is it? Or 4. If it's 5 centimeters and above with one node in grade 2, she could potentially access abemaciclib.
Yeah, but it's 3.9. It's 3.9 grade 2, and with negative, with 1 lymph node, so she doesn't really qualify for that. We know that. We have the details for that, the data for that.
I guess what we don't know is if she was 5 centimeters, for example, what we don't know about this population is whether they could do just with abemaciclib and without chemotherapy. And that's something that we see quite often in more elder patients that may not be fit for chemotherapy. And we don't know the answer to that.
But she may be candidate for ribociclib.
Yes, but I guess that's yet to be fully confirmed. She's node positive. I think they included lower risk, including no negative patients, much less in numbers. But we have to think about the fact also it's 3 years of ribociclib. So if she's not committing to chemotherapy, maybe she may not be as keen to commit for 3 years of ribociclib, but this is all things to discuss with her.
Well, she actually said, no way I'm going to have chemotherapy. That was the initial response. So, okay, I think we are a bit late, but I think it was a very nice talk, and we didn't want to spoil it just for the sake of being punctuated on 4 o'clock and not on 4:10 I think we sacrificed the comments and remarks and all these things, Mihaly, and I think for a good reason we sacrificed all those. Before I give the microphone to Michalis for the last comments, I would like to thank everybody for all the effort, for all the cooperation, for I know the problems that every single one of you has, but despite those, you are here and you are supporting us, both the attendees and the panelists and the speakers and the rest of the board of the Hellenic Society. So just a big thank, nothing else. I want to thank you all for everything. Michalis.
A big thank you from my side too. It's always not frustrating. It gets us nervous to get prepared for this webinar because there's a lot of work hidden, which is not visible to everyone. We have been preparing it for several months, and we have worked together with the presenters very close for months. But every time we finish the webinar comes to its end. We feel happy, we feel pleased, and this is what we feel now. And I hope that you found it not only productive and informative, but enjoyable as well. It is a fun way of, updating yourself. And it's a fun way of listening to the ideas, opinions of people who have a lot of experience, and you usually have to travel somewhere far away to listen to their talks. Before saying goodbye, I'd like to highlight something. Everything is done because of Sophocles. Sophocles is not only the brains, but it is the soul of this webinar. And I think I personally owe him a very big thank you.
No, I think you're exaggerating now. It's a teamwork. We're all on this one. It's a teamwork. So
you do 99% of the work. And of course, I would like to thank you all for being here today. We had a great, I think, turn up here today. I don't know the numbers yet, but it is in a very good area. A big thank you to all of you, and I do hope that you enjoyed it as much as we did.
have a nice evening. Thank you all.
Very much. Congratulations. It was really great.
See you next year.
Next year, promise to be here next year.
Thank you very much.
Bye,
for the
everyone.
invitation.
Bye.
Excellent. Congratulations.